This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 635, recorded on July 3rd, 2020. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York State, Daniel Griffin.
Hello, everyone.
And also from New York State, Chuck Knersch.
Hey, everyone.
And from Fort Lee, New Jersey, Dixon Despommier.
Hello there, Vincent. Hello there, everyone.
It is time for our weekly COVID-19 update. Daniel, I have a couple of questions. Maybe do you want to give your update first, and then we'll do them?
Yeah, let me do that. I'll hit everyone with the update, and then we'll hit the questions.
Very good.
All right. So first, I'm going to start off with a quotation. I think I get feedback. People seem to like these, so I'll continue. And this was actually suggested by a patient. It's another Winston Churchill quote, and it was, "If you are going through hell, keep going."
I haven't heard that one. I like that one. I like that, actually.
It seemed this is one of those gentlemen who's a long hauler, right? Who's still suffering with COVID. So I don't know if he was speaking about himself, our world situation, but it seemed appropriate. So as of today, as we're recording this podcast, early July 2020, Plainview Hospital had reached a couple of milestones. One is that hospital, in this hospital, over 2,200 individuals with COVID-19 were taken care of. Wow. And the census peaked at 165 patients in the hospital at one time. And although a few patients were seen by, there were a few other ID docs who saw like a handful each. It was really one of my partners in New Jersey and myself that saw almost all these patients. So sort of a tremendous amount of COVID-19 experience. I also saw people, Anuja and I also saw people at a few of the other hospitals in the area. Also, I was out at urgent care centers. And as I think I've shared, I do a bit of outpatient work as well. So seeing patients in person in the outpatient setting as well as telehealth. So the milestone, though, is today. When I went to work, at least this morning as of 9 a.m., this may have changed a few hours later, there were 0 patients in the entire hospital that were active PCR positive COVID patients. So that is the first time since February.
Wow.
Goodness.
Yeah.
Good. Well, if you were California, it would be different, wouldn't it?
Or Texas, or Florida.
Yeah. No, and I think that's important. You know, the rest of the world, the rest of our country, things are not so great. We just, the other milestone, right? We're now past 50,000 cases in a single day. So things are not going so great.
There are more states, though, that are going down than are going up.
Okay. So
there
that's... the ones that are going it up, they're making up for the rest.
Arizona, Texas, California, and Florida.
Yeah,
people are just not listening. They're just doing what they want to do, I think.
So let's hit testing.
Mm-hmm.
And I just I was talking to Vincent a little bit as we were waiting for Dixon to address technical difficulties. Not sure they were ever addressed, but there was actually every Wednesday there has been since this began. I don't know if it was late March, or I think it was late March when this started. Columbia does a COVID-19, Columbia University does a COVID-19 symposium. This is the second time I spoke, and this time I was speaking about testing. And it was a lot about how often do you actually have to test, how quick do those results have to come back, what's the sensitivity, to really getting a handle on a virus with the transmissibility of this. And it's a little frustrating. One of the big things we're running into is that there are delays. You get a test, there's a delay. So as you're waiting for that test to come back, that person is potentially infectious. There also is an issue with how often people are being tested. But unfortunately, when we talk about Tetris and the whole concept of testing people, determining who has it, we don't have the frequency of tests that we would think would really make that work. So even when people say, "Oh, a certain number of the states have adequate testing," it's really not adequate in the sort of modeling that we did, which will hopefully come out as soon as it gets through peer review. I'm still sort of anti preprint. I still try to actually get things peer reviewed before our stuff gets out there. But I also, while testing, I wanted to make a point of repeating concerns about serology, right? What happens when someone has a positive serology test? What do we tell people? And I think this has become even more concerning with actually some information I was talking about on Fox News for our listeners that listen to Fox News. And this was the whole issue about the durability. So a couple of things that we now have seen is that when patients have PCR positive COVID-19, so really solid, this is COVID-19, not everyone produces a measurable antibody response. We're estimating about 80%, which means 1 in 5 go through the course of disease and never produce what we recognize as a positive serology. The other, and this was sort of the concern, was if you then look at people 2 months out, everybody's antibody levels are trending downward. And if you look at people with more milder disease, maybe 40% are now serology positive. People who were sick enough to have high antibody titers, you're starting to see them turn serology negative. So you heard, maybe people have heard about these. They now have COVID parties in certain parts of our country where young people all go together and there's a cash pool. And the first person who can get a positive COVID-19 test gets all the money in the pool. I'm looking at Vincent's face to see if he's
I didn't
disturbed by this.
That's ridiculous.
That's absurd.
It is absurd. And part of the thing I sort of want to point out here is we do not know, there's this whole concept of reaching herd immunity. We don't know if there's durable immunity after being sick with COVID.
Mm-hmm.
And so that's an issue, the whole idea. And I think a lot of people want to think about the idea, I'm going to go out, I'm going to get it over with. I'll no longer have this sort of Damocles hanging over my head. Now I'll have this protection. I'm not sure that there's any guarantee that occurs. I'm not sure there's any guarantee that whatever immunity you have is durable. So this raises a lot of concerns with what to do with the serology. And I'm going to actively discourage people from going to these parties and getting COVID. Think about the issue. We don't even know, as it is with other viral illnesses that have a significant inflammatory component, if a second bout of COVID is worse than the first. Mm-hmm. Try to avoid getting COVID until we have better understanding of what to do, and hopefully avoid getting COVID till we have the ability to make you immune. And I don't know whether or not that's going to be generating protective antibodies or whether it's going to be T cell based. So I'm sort of on board with some of the other discussions about we've put a lot of eggs in the spike basket. I don't know if we should be doing that, but I think that's a little bit of cause for caution. I want to talk about the long haulers. Vincent asked a few times, and I'm always curious about how many people end up getting COVID and never really getting better. And I can't say never because it's only been so many months, but months later, 2-3 months, still feeling sick. There are now support groups. This number is getting into the thousands. One support group alone is approaching 4,000. So there are thousands of these people in the U.S. alone who got sick and still don't feel well. I feel bad because I see some of these people and they go to providers who sort of discount it, like, hey, buck up, time to get over that. You were sick in March. And there was an article that came out in Respiratory Research where they said, okay, 30 days after discharge, let's do some objective measurement on pulmonary function. Basically, you were seeing objective evidence of impaired diffusing capacity, lower respiratory muscle strength, lung imaging abnormalities in the majority of COVID-19 patients, even a month after discharge. So we have, objective evidence that something is not all better. And it's very consistent, I'll say, the clinical presentation that I hear from different patients, this description of a chest heaviness. And what I'm beginning to really say is almost like a histamine-like experience where they say, you know what, sometimes at the end of the day, I feel like, oh my gosh, I just got too much sun, my skin. And they're like, but I didn't actually go outside because I'm staying in my room. So that's a very interesting, maybe there'll be some clues to the pathology or the pathophysiology there. There's persistent fatigue. I was taking care of a nurse just this week who was like, I pride myself on being like a hard worker. And I just have this fatigue. And, I think particularly bad because here's someone who was in the front lines with us. And she's just like, I want to get back to work. The brain fog is described. This weakness, which we have objective measurement, they have trouble with, doing these 6-minute walk tests. So the weakness, exercise tolerance. There also seems to be, in addition to these things, some, say, mental health impacts. So depression, anxiousness. And there's actually a discussion, maybe a lot of people who are sick enough to be in the hospital, but maybe we should extend this need to talk to someone. Not that I would discount this as a psychiatric in any way, but I think there are psychiatric impacts to COVID. So neurological impacts is probably better to say. Most people describe that I talk to as having symptoms, particularly the chest heaviness, that are worse in the morning, get a little better throughout the day. But a lot of people have a 1, 2 in the afternoon, I'm just done. So there is some suggestion in some of these early reports that this is more often seen in younger individuals, that this has a female preponderance. So I say the older men die, the younger women suffer. There are, as I mentioned, there are now thousands of these individuals in support groups, but I'm seeing women, I'm seeing men, I'm seeing people of all ages. One of the interesting things several of my patients have stumbled across on their own, and one was recommended by a pulmonologist I work with at NYU, was the use of something called NAC, or N-acetylcysteine, or mucomist. And I think the pulmonologist was trying it as a mucolytic. But some of these patients are actually saying that it seems to have some impact. So maybe there's some antioxidant or anti-inflammatory impact. So we're learning. I'm not want to be endorsing that, but just sort of commenting on that. Non-steroidal anti-inflammatory drugs, and I'm going to, I'll just say it right here. Early on, right, that was another one of the dogma, like don't use non-steroidal anti-inflammatories. It was a letter by a French, I think it was pediatrician. And, the WHO has now looked at over 70 studies, and I'm going to quote them when they say, at present, there's no evidence of severe adverse events, acute healthcare utilization, long-term survival, or quality of life in patients with COVID-19 as a result of the use of NSAID. So these patients actually, and this is also an issue in people sort of early on, they actually respond quite well to ibuprofen, Aleve, aspirin. So just another thing that, was sort of pulled out of our arsenal that actually doesn't look like there was any evidence to support pulling that out. Outpatients, most of the focus, right, has been on the patients in the hospital. But as we've always pointed out, the majority of patients never end up hospitalized. And there's now some concrete data addressing this population. There was a early release that came out, MMWR, looking at the characteristics of the outpatients versus the inpatients. And some of this we'll sort of say is intuitive. The outpatients tend to be younger. We knew the inpatients were older. The outpatients have fewer comorbidities, sort of the opposite. We knew the inpatients had more. The outpatients were more likely to be of lower socioeconomic status, sort of an interesting. And by 2 to 3 weeks after the onset of symptoms, they did a survey. Basically, a third of patients were saying, I'm still sick. So the idea that this is only a 2-week syndrome, that's not true for a third of people. A third of people by 2-3 weeks, they're still having this. So the other, I want to make a point, and sometimes people say, "Oh, I haven't heard about something in a little while; it must have gone away." So I want to make a point of just re-emphasizing thromboembolic complications. This is a disease that involves thromboembolic phenomenon, and there's some interesting things coming out now about platelets and megakaryocytes playing a role. And actually, very quickly, right? Our first two publications on this were on thromboembolic complications out of our group. And first it was pulmonary emboli, but then a week later we were actually publishing on arterial clots. And one individual actually had the arterial clot removed, and it basically was shiny white platelet rich. So some of the autopsy stuff we're seeing where they're looking at this is consistent with what we described early on in the epidemic. Summary of current therapeutics. I'm going to try to keep this short today. Things we're not doing. We're not using much in the way of hydroxychloroquine. We're not using much in the way of famotidine. We're not using much in the way of azithromycin. I keep trying to point out it's a virus. It's not malaria. It's not an ulcer. It's not a bacteria. Remdesivir, we now have a price. You can get a 5-day treatment of remdesivir for $3,120. So sort of interesting. Their argument on pricing was this is going to save the hospitals a lot of money, and my point was, I'm glad the hospital is going to jump in and pay for that because it's going to save them money. Just by the way, if I'm unable to make a decision, I don't want to spend the $3,000 on remdesivir. I'm going to save that for something else. Steroids, right? That's now sort of gaining traction. It's interesting, right? Even though we've been talking about it for a little while, sort of the history of that and the data, it's going to take people a little while to break from the dogma to, as we said at business school, pivot their thinking, or what was the rhetoric we use at business school? But people probably are familiar with that. It's when you change what you have to say by 180 degrees, right? But you do it in, our thinking will evolve. Anticoagulation. This is interesting because now there's more discussion about maybe in addition to blocking the clotting cascade, maybe we need to be thinking more about antiplatelet agents. And so on one of the anticoagulation panels that I'm working on, this is actually hopefully going to be addressed.
Especially for outpatients, because you worry they're not being closely monitored. And I don't know how many cases you're seeing, Daniel, of outpatients that are sort of on the verge of needing to come in the hospital, because that might be a good group that you would look at antiplatelet therapy, I think, right?
Yeah, so I do the telehealth, Chuck, and I was taking care of a patient on Tuesday who's in Houston. I've been, remotely caring for people in California and Texas, other parts of the country. So this was a physician. It's actually a friend of his, is a TWiV listener. So he was like, "I got to talk to Dan because you've got COVID." And as we had our discussion, he had done a few things that I wasn't, happy about. There was some azithromycin and unnecessary steroids in a person who didn't need these things. But then we talked about the fact that he had previously been on chronic aspirin. And it just he wasn't handling it well with his stomach. And I was like, this might be a time for you to start taking the aspirin, stop taking all that other stuff. So, in the outpatient setting, physicians have certainly on a case-by-case basis made recommendations about platelets. We know that about antiplatelet agents such as aspirin, and we know that certain groups are at increased risk of strokes, right? So if you're in that setting, it makes a lot of sense. But again, we're waiting for data to help us. But most patients will not end up in the hospital. So we need guidance on what to recommend for those people.
There's an interesting movement afoot among professional athletes, particularly male professional athletes, particularly football players. A lot of them express great concern about restarting the season because of the close contact and the lack of proper knowledge as to whether the person opposite you on the line is infected or not because he's asymptomatic. And the other thing that they're worried about, I've heard them express this on ESPN, is that what if they do get it and then they have all these late onset sequelae, muscle weakness, fatigue? Yeah. That's not so good for a professional athlete supposed to perform at the peak of their abilities. So I think this has got huge ramifications to have a COVID party among young people that have presumably very bright futures ahead of them in various walks of life, to have that threatened by such trivial thinking. That's just absolutely antediluvian. It's just
I see Chuck also not approving of this. One of my other hats is I'm the infectious disease expert for the Long Island Islander hockey team. which I played hockey growing up as a kid. And, I still have all my teeth, so I must have been really bad. No, this is a big issue for a lot of the sports teams, right? Like, how do you play your sport? How do you practice? How do you do a lot of the things you do, and stay safe? Because, not you think, oh, I'm young, but what we're concerned about, right, is, if you end up as an athlete with, you've lost 10% of your pulmonary capacity because of that's the problem. That might be what prevents you from having that career you were interested in. So this is a huge issue. And think about with the young people, like, oh, I got my COVID and I don't have to worry about it. Why don't you go for a run? And then you realize, I can't run quite as well. And, and we don't know the long-term impacts yet. So there's a lot of issues here.
So Daniel, you and I have children that are college students, and I'm particularly concerned about them not being able to get back to their, their unusual routine come this fall. And CDC just put out their guidelines for school reopening, and they do address the university setting. I was impressed by the lack of recommendations around routine testing. Maybe it was done for pragmatic reasons that there aren't enough tests, but I do know already that universities are planning, I've seen some, and I won't name them by name yet because I think it's still sort of draft, but weekly testing. Vincent, I've heard you say that in TWiV a couple of times, that wouldn't it be great to be able to test on a weekly basis?
Well, Cornell just had an editorial in the Wall Street Journal saying that they didn't have the capacity to test everyone on a weekly basis. They're going to try pooled testing.
I'll weigh in on this because this is not good, and there's several issues here. So the first I want to point out is that the people, and someone asked me about this recently. So, what about that thing in kids? And so I will say the multi-system inflammatory syndrome in U.S. children and adolescents, it didn't go away, and there actually are 2 publications in the New England Journal of Medicine that really their focus was to make a strong connection, to say, no, this is related. This is a COVID-19 connection here. This is not just random. And so they, in New York State, so the New York State Department of Health has had almost 200 cases reported to them, and 96% were classified as confirmed. So, if anything, we think this is underreported. We do think that there is an issue with COVID-19 causing harm, pretty significant harm in a certain percent of children. But a couple things I want to say here, because this is important too. You want to put this in context of the age-dependent effects of COVID-19. And so the CDC published, really it was April 2nd, right? So really sort of early on, when they started noticing that there was, less than 2% of the cases were being seen in people under 18, where people under 18 make up over 20% of the population. So there was a much lower incidence of cases. We could talk about why there might be underreporting and undertesting in that population. But the American Academy of Pediatrics came out recently with a strong recommendation where they say the AAP strongly advocates that all policy considerations for the coming school year should start with a goal of having students physically present in school. Mm-hmm. And there's a big debate about this. So I'm going to come out and just say I'm actually on the side of opening the schools. I think it's really important, and I sort of the slogan of open the schools, not the bars. Right. And I think physicians get asked about, like, what do we think about opening the schools? And, I think it's great to have opinions, but they should be based on facts. And we do know that when we don't have schools, not every child has a great home environment. And I've already talked about this a few times. We're seeing an increase in drug abuse, in alcohol, in domestic violence. Without schools, we don't have access to the kids. We can't find out that there's a bad home situation that we might want to be able to help with. And I think that there are a lot of bad home situations. I was in the hospital today, and one of the hospitalists was like, "How come we're seeing so many like alcoholic withdrawals and GI bleeds?" And I was like, "Yeah, because say what is it? Liquor stores were considered an essential service, right? And so we are seeing so that there is clear harm to keeping the kids out of the schools, and that has to be balanced. But how do you balance it? You open the schools in the right way, and testing is critical. Mm-hmm. And and the testing has to be frequent. It has to be accurate. It has have rapid turnaround. And, we just dumped trillions of dollars into the stock market to do whatever to the Dow Jones. We need to put billions of dollars into testing so we can keep our kids safe. And this is a political will. It's an economic will. It's a question of priorities. And I think our kids and schools and education, they're priorities. Yeah. And we need to make this happen in a safe way.
I so agree. I think that we can afford this. We could have been working in these 3 months on rapid, affordable testing, and there's just no will, as you say, to do that. It's very disheartening. You asked me before we came on, how do I feel? I'm very depressed about this because we could be doing this, and you've shown you can do lots of testing rapidly.
Yeah, we had a couple summer programs in the area. One was an outdoor summer camp with over 1,000 kids, and then all the counselors and staff. Another is it's a sailing program with 150 kids plus all the staff. And so we talked to them. We went through programs with them. We said, okay, you need these people all tested. We will test everyone before the program starts, and we'll even set up periodic testing through the program. And we set up drive-throughs. We did all the registration over the phone, and basically, we were testing, hundreds of kids every day. I mean, this can be done. It just takes the will. You just have to decide it's a priority.
Daniel, Rich asked me to ask you if there's any information yet on convalescent serum.
Yeah, there was the first randomized control trial on convalescent serum, and it did not show benefit. So,
interesting.
Yeah, I should probably share that with you guys. We get that up on the PWB website for people to take a look at. What we saw in our experience, was if it was given late, we actually saw people not do well because it's FFP. It has clotting factors. So if you gave it to people, we had a number of people in the intensive care unit who got this at, part of this Mayo clinical trial. And during the second week, all their D-dimers tripled. Wow. And we had a lot of complications. Actually, most of them died. But my thought would be is if you got it earlier before that thromboembolic period, that it might have some benefit. But again, it goes back to the issue is what is helping us clear this virus? Is it antibodies or is it an effective cellular response? Mm-hmm. So, a lot of this goes back to stuff we just don't know yet, the science here.
That's right. But I think the recovery trial has one convalescent serum in progress, right, Chuck?
Yes, it does. I think you need both. I don't think it's going to be only B-cell responses, T-cell responses, but in general, for viruses like this, you do need a B-cell response. You need neutralizing antibodies. I wouldn't rule that out. And maybe it's I think you're right, Daniel, that if it were to have an effect early, the steroids maybe later, given that the benefit in the steroids seem to be most in the intubated patients that were quite severe.
Daniel, we have an email from an internist in Washington, D.C., who writes, keep up the amazing work. What a terrific asset to have such smart people focusing on understanding and communicating the latest science with all its imperfections and uncertainties. So he has a patient whose disease course scares me as the implications are potentially massive. It would be great if you could pose this question to Daniel tomorrow. He just sent this on your show, and he knows the timing. It's great.
That's great.
All right, 54-year-old male patient, mild COVID, cough and sore throat with positive PCR on April 4th, recovered quickly, 2 negative PCRs in subsequent weeks, never got an antibody test. He presumed he was immune, however. When his son contracted COVID in mid-June, they did not distance. On June 22nd, my patient developed fever and cough, and the next week tested for COVID was positive. His symptoms have become increasingly severe, including O2 sat of 88, fever 103. He's on his way to the hospital now as I type this email. Here is my question and concern. if we believe the story, and I have no reason to believe the PCR test in April was a false positive, this appears to be a perhaps dengue-like worsening clinical syndrome upon reinfection. Are you seeing any cases like this in New York? And if so, do you believe these are rare one-offs, or could they have greater implications for the safety of vaccines or even the ability to develop natural herd immunity?
All right, so Clay, this is sort of right in lines with some of the concerns that I've had when we talk about the serology testing. Is we saw several people in the New York area who got sick with COVID. They went home. We thought, oh, this is a win, and then a couple weeks later, they'd come back, and now they're super sick, and they would die. And in the height of the pandemic, there was no way to know. Was that a reinfection? Was that somehow some odd biphasic variant of this? I don't know. And what you're describing sounds to me like a potential reinfection. And it sounds like this reinfection was worse. Obviously quite a bit worse. I mean, he initially had mild COVID with cough and sore throat. Now, the man is on his way to the hospital. So these are the things I worry about, particularly people go to these parties, right? So they're going to become immune to COVID. Maybe they're actually going to become hyper susceptible to a severe syndrome upon reinfection. I mean, this stuff we don't know and we're learning about, but it's why I think we need to be cautious. You don't want to go get this and make certain assumptions that I think a lot of people make. They say, oh, it's in general, you get something, then you're done. You're not going to get it again. We don't know, because that's certainly not the case with dengue. You get one serotype of dengue and then you get reinfected with the second. I had, I'll share this. I was in China in the 80s, right? I don't know if people know, but I used to speak Mandarin and do translations, and I was hired to teach in Kunming at one point. So in 1988, I don't think there were a lot of Americans in China at that point, but I got quite ill, came back. And then several years later, I was in Zimbabwe and Zambia, and I got sick again, and it was felt to be a second infection with dengue, where my platelets went down into the teens, and the call to the parents was, well, if he's here in the morning, we'll let you know. And some viral illnesses, the first time is not so bad. That second is when you get these really severe manifestations. We don't know that. We're still learning about COVID-19. So let's not make any assumptions that end up with tragic consequences.
But this is still within the realm. Let's also not assume that this is reinfection, right? It's 8 weeks afterwards. And, some of the progressors in literature, have been positive much longer than 8 weeks. So the two negative tests in between may be the performance characteristics of the test as much as reinfection. So let's not get all depressed about, vaccine approaches right now because of this one case.
Yeah.
I think we're really going to need to know. You have to sequence, virus before and afterwards to confirm something like this. And we know how hard that will be with the absence of access to BSL-3 labs.
Yeah. It was interesting because I know early on there was this assumption, and a lot of doctors wanted to get serology tested because, if I'm serology positive, then I'll go volunteer at the Javits Center because I won't have to worry. And I don't know if we know. I think we have to be careful about making assumptions, but I would hope, I would suspect that our vaccines are not going to cause this, but again, it's hope. I don't know.
It has to be studied. That's why that's why there will be mega trials. Where safety can be really carefully, studied.
Yeah, and in fact, in the FDA guidance they issued this week, they say, look, please design your trial so you can look for vaccine associated disease, right?
Yeah.
And specifically for that, it's important.
Yep.
Daniel, anything else before we say goodbye?
Well, I think I want to thank everyone for who's come to the Parasites Without Borders site and donated to help support FIMRIC's site in Bududa, Uganda. For the month of June, with the Parasites Without Borders match, we raised $12,304 for FIMRIC's site in Bududa, Uganda. And I like to point out that this is a clinic that is fully staffed by local Ugandans. This isn't us coming in trying to save the day. These are people on the ground in Uganda who your generous donations really help, because there's food insecurity at the moment. There's issues with transportation and access to medicines, and what we'll announce today, I guess, when this is that we're going to extend this fundraiser until the end of July. So thank you. Please go ahead, visit parasiteswithoutborders.com, and we will continue to double everything that comes in to help support this clinic in Uganda.
Daniel, thank you again. Really appreciate your coming.
No, thank you. It's a pleasure as always.
And Chuck, thank you as well.
Good to see everyone on Zoom today.
And Dixon, thank you.
Partially, you're welcome.
Partially? What does that mean, partially?
Whatever you can hear, you're welcome.
All right. Okay. Joining me today from Madison, New Jersey, Brianne Barker.
Hi, it's great to be here. Sort of overcast, but 89 Fahrenheit. Getting ready for a nice weekend off.
Enjoy the parades and fireworks, Brianne.
Maybe I'll see some fireworks outside, but that's about it.
Also joining us from Fort Lee, New Jersey, Dixon Despomier.
Hello, everybody. And the weather here, Brianne, is remarkably similar to the one that you've described. So
I'm waving to you out the window, Dixon. Can you see me?
Well, that's right. I can almost see your house from here, as Sarah Palin used to say.
She said that about you?
No, she said
no, that was about Russia.
Something about Russia. She could see Russia from here, but that's crazy.
Yeah, someone asked her, do you know anything about Russia? I said, yeah, I can see it from here. Great. Also joining us from Western Massachusetts, Alan Dove.
Good to be here. It's 77 Fahrenheit, 25 C right now, but it's about to start thunderstorming. Got some storms rolling through just to the south and west.
And from Austin, Texas, Rich Condit.
Hi, everybody. 92 degrees and sunny, headed for 97 this afternoon. It's summertime in Texas.
It's getting hot
Proving
there.
that COVID-19 can spread during hot, humid weather.
I guess so.
In case the Philippines hadn't already proven that to us, yeah.
That's right.
In fact, the U.S. set a single-day record for the 5th time in a week.
So sad.
And people are saying stay home this weekend. I think parades are canceled. Many fireworks are canceled.
Absolutely.
And, of course, the governor of Texas ordered mask wearing in public, reversing the course, right? All Texans and counties with 20 or more cases, and that includes Travis County, right, Rich?
Yep, Travis County. That includes Austin. And I would say that on top of that, and this is a local ordinance in Travis County, including Austin, all public parks are closed for the July 4th holiday. And they're even, they're closing boat ramps, so you can't get onto Lake Austin or Lady Bird Lake. They're closing down the trail around the lake.
No jogging.
No, they're gonna close the trail. I have a spy downtown who lives downtown, and I've been corresponding with him to get the news from down there. And I also put in for you folks the link to the key indicators site by the Austin Metropolitan Statistical Area for COVID cases. And it's got this one graph that I really like that's a 7-day moving average of hospital admissions, which I think, given the vagaries of testing and et cetera, is one of the best indicators of what's going on.
Yeah.
Yep.
And if you have a close look at that, you'll see that on June 9th, the hospital admission, the 7-day moving average on hospital admissions was 11.3 cases today. And I choose that date because that's the last low ball. It was pretty much steady at around 10 cases per day all the way back to April. And then it took off, and it's still going up. I don't know if that's not quite it's not exponentially, but it's going straight up.
Yeah, that's not a good looking graph.
No, it's not a great looking graph. And yesterday, the 7-day moving average was 58.3. So that's 5 times the average from the middle of June. And there's no indication on the graph, at least, that it's slowing down or anything like that. So and
they've got a doubling time in the lower right of 12.
Yes, 12.6 days. That's right. So we're in the thick of it. And
Texas always has to be first, though, don't they?
I will be interested. I think it's good the governor changed his mind.
Oh, Rich.
and
You used to be
ordered
in
masks.
Florida, and now you're in Texas. Is there any link between you and? No, that couldn't possibly be
No.
right.
No, trust me. I take no responsibility for any of this. But yeah, good for Greg Abbott for. I mean, you can debate this all you want, but it was a good thing to order masks, and I'm sure
It's
that
better to admit you're wrong late than never.
Yes.
Yeah,
exactly.
It's true.
Okay. And what I'm really interested to see is what sort of a reaction there's going to be from the community. All right. You're already seeing pushback from people who say, well, I want to go boating on the 4th of July. We just want to have some fun.
Exactly.
I looked at, I watched the actual video of his announcement on this. And he was quite good. He appealed to the public to get on board with, saying this is a group effort. We have to cooperate because we're in trouble here. Okay.
Now, has he done anything besides the mask mandate, like closing down?
The bars are closed.
The park. So that's statewide. That's not just
statewide. The bars are closed. I believe
the bars are closed. Okay.
Okay. And he also. There was something about restaurants. I think they either did not do the next stage of opening or backed off a stage. So it went from 75% to 50% or something. So incrementally, he has been reversing the progress of Texas towards reopening in response to a serious flare-up.
Yeah.
Okay.
Have people been wearing the masks and complying?
Well, it's too early to tell. I asked my spy about this, and he said that he was down because he runs every day on the trail. And he said they went down there today to run, and there were volunteers out saying a trail was closed and you couldn't run. I'd have to look. I don't recall that he said anything in particular about mask use. So it's a little early. We'll have to see how people comply over the weekend. I believe the 4th of July, the fireworks have been canceled as well, but I'm not 100% on that. At any rate, we're taking steps in the right direction.
Yes. We're in the opposite situation up here. I don't intend to gloat because this is not a cute situation at all, but New England has, by shutting everything down and having all these mandates, we've actually got the curve going down. And they're talking about on July 6th, they're going to move to, I think it's phase 3 or 3A or something in Massachusetts of reopening stuff because the numbers keep trending in the right direction. So it is possible with non-pharmaceutical interventions to get this thing under control. And I wish best of luck to the states that are still struggling with it.
However, if you start to come out of lockdown and you don't do things properly, you have problems.
You've got to back up again. And that is probably more economically damaging than the lockdown in the first place, because now you've added this layer of uncertainty.
Yep.
And psychologically, it's very, very depressing.
And it's also nice to see places like New Jersey that are looking at the data and slowing those plans for moving forward and not just sort of blazing forward.
What we need to be doing is testing more, and we're still not doing that. And that's really a key part of coming back. And as long as we don't, we're going to have outbreaks. And in my opinion, the lockdown should have been used in part to get testing ramped up, rapid testing, and it wasn't. So,
we didn't ramp it up enough. We certainly are doing better than we were in mid-March, but that's setting a low bar. We're still nowhere near where we need to be on testing.
I don't know. So I wanted to just point out that Raul Rabadon's book has been published. I got a copy this week. There you go. Understanding Coronavirus. It is rather thin.
Well, you had to write it in a matter of weeks.
There's a lot we don't know.
So Cambridge University Press, you can check it out. It's a nice little.
I think in this case, thin is good.
Yes,
because
people might actually read it.
Yes, exactly.
Yeah, nice. It's nicely illustrated, and we had Raul on a couple of weeks ago to talk about it. So check that out. Okay, I feel like Oprah with the book club. Here you go. Check it out.
Vinny's book club.
Vinny's book club. A couple of things I wanted to chat about. The news, the paper on the D614 amino acid change in the spike, which we talked about a while ago as a preprint was published yesterday. So the news headlines are all saying the virus has mutated to greater transmissibility. And Dr. Fauci has said the virus may have mutated, which is better. But I just want to review what's this about. Single amino acid change in the spike, D614G, has become prevalent in many locales. That in itself doesn't mean a lot, but because it could be that the change arose and then it was just introduced places. And if it were neutral, it would still be there, right? It doesn't have to have been positively selected. If you think it has been, you have to prove it, and that hasn't been done. The paper has some cell culture experiments where they make pseudotype viruses with and without the change, and they say it's more infectious. It ranges between 2 and 9-fold more infectious, but these cells are completely irrelevant to human transmission. So then they go in humans and they do some PCR and they say, we see a little more RNA in the upper tract of people infected with this variant. Doesn't mean anything, folks. Could be a lot of reasons for that. You need to look at infectious virus, and then you need to look at transmission amongst people. None of that's been done. So I don't think any of these conclusions are justified until we have the data. We may never, because if you remember with Ebola virus, a similar single amino acid change in the spike emerged, propagated throughout West Africa, affected in a positive way virus reproduction in cells and culture. So people were saying it's increasing transmission, but it turned out that it attenuated virulence in a non-human primate model. And that's the end of that. We never heard of that one again. So be careful about these proclamations.
So, Vincent, how many changes does the virus have to make, or it is made in the viral genome before you call it a different strain than the one you have?
My definition, a strain has a different biological property.
I see.
So, and this thing has a small difference in cell culture. I'm not sure that qualifies as a strain or not. It could be debatable. But they haven't looked at actually SARS-CoV-2. It's a pseudotype so far. So we'll see.
And I know you've made this point before. I think it's a really important one. There isn't necessarily a reason that the virus needs to be selected to be more transmissible. It's pretty transmissible as it is.
It's doing just fine.
Doing a nice job.
Oh, that's a good point, because if you're arguing that a change is positively selected, right? You have to have a selection for it. And at the beginning of the outbreak in China, this thing was damned transmissible. Now, all right, people are saying, but we're sheltering. Wasn't that put pressure on the virus? No, because not everyone is sheltering. There's still transmission. So
I don't think that this is becoming more transmissible into my shelter department.
No,
which is the only pressure we're really putting on it.
Okay.
So I want to add a couple of things. I don't know if you said this, Vincent, but part of one of these papers, in terms of looking at the virus, is that the either the pseudotyped virus or the virus-like particles actually had a higher content of the spike protein in the particles, and they shed less of the outer domain of the spike protein. So there's, at least in theory, because of that, and this is consistent with the cell culture experiments, a higher potential for this thing to bind to cells. So that's all consistent with the conclusions that are being made.
By the way, there's no evidence that this increased the pathogenicity at all.
And that's the other point I wanted to make.
Yeah, there's
nobody is saying anything about pathogenicity.
Right.
Okay. And I don't think the public necessarily, in their minds, discriminates between transmission and pathogenicity. They hear mutant transmission and freak out. Okay. And this thing could be maybe more transmissible. All that means is that it's going to be a little harder to control. It doesn't mean that more people are going to die necessarily.
Yeah, but in the movies, mutant virus is always something.
Exactly. That's the problem.
They're very scary.
Attack of the
other aspect is this variant is neutralized as well by antibodies as the other. So, okay. The other thing,
by the same antibodies.
Same antibodies.
Yes.
So this week in the Wall Street Journal, the president of Cornell, Martha Pollack, and Michael Kotlikoff published an article, an opinion saying why Cornell will reopen in the fall. And so this is my alma mater, and this kind of burned me up. I agree that they should open. I think schools should open, and we're going to talk about schools in a moment. But the reason they give, there are two things about this article that really piss me off.
Frost your cake.
So they have a modeling study which suggests that students are not going to come. They're going to come to Ithaca, but not if there's no school, they'll still come to Ithaca, and therefore they'll be less safe if they go to school, which seems to me just ridiculous. Just open school. You don't have to make a lame excuse for it. I don't get that at all. And I'm not sure their modeling is right. It's a model, right? Okay, so that's one thing. I mean, I think you need to go back to school. You need to figure out how to do it safely. So they're saying, then she says, we can't test every student. It's impractical and cost prohibitive. To which I say, BS. You are looking at the bottom line. You're talking about money. Your money is more important than your students' health. You could have done this in the lockdown. You could have worked on it. You got PCR machines up there at Cornell. You could have done this. You could have spent money on it. You could test people frequently and rapidly. So this is BS. They're going to try pooled testing, which, the FDA said you could try it, but you have to validate it with the FDA. So in my view, that's the safe way to go back, is to test students frequently, face masking and all that. But don't say you can't afford it. It's not practical. Someone told her this, and it's just wrong. You should have sorted it out. And parents of Cornellians, they care more about the bottom line than your kids. All right? That's why they're saying this. And I'm sorry, that's what a university president does. Okay, that's my little rant there.
Yeah, sorry. If you can't afford to test the students frequently, then you can't afford to open school.
I know schools that are doing 3 times a week. They're doing it.
That may be a little much, but you should have regular testing of the entire student body.
I agree. You could quarantine them and everything.
And in fact, the military has already shown the way on this. There was a report, I think it was in MMWR, about the Air Force Basic Training Program, where this is, military basic training. You put a gazillion people in one room and have them do push-ups, and this is just a horrible setup for you're going to spread the virus. So in typical military fashion, the Air Force lined everybody up, tested them, and some people had arrived with SARS-CoV-2. They isolated them, and they proceeded with the rest of the group, and through regular testing, tracing, and isolation, they played Tetris, and they were able to completely control it in that setting. Now, that's a setting that's more extreme than a college campus because people are not coming and going. But it shows what can be done if you take this seriously enough, and if you have obviously DoD-sized budgets, so you can just buy whatever you need. And Cornell's maybe not quite in that league, but come on, they're an Ivy League university. They've got an endowment. They've got money. They can very well afford to either set up testing themselves or send testing out. And I agree that that's a bogus argument.
What?
Did anybody calculate how much the Air Force spent on testing?
I did not see those figures.
The U.S. is spending trillions on recovery. A lot of that is going to the pockets of already wealthy people.
That's kind of how we do things.
They could use that for testing. I'm not just blaming Cornell, by the way. It happens to be I got an email because I'm an alma mater, blah, 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 because I'm an alum, right? But Columbia is doing the same thing. Many other schools are doing the same garbage. They're saying we can't afford it. It's not logistically possible. It's BS. I'm sorry. You had time to do it. What the hell were you doing during this lockdown? Having pizza? Sorry, Brianne.
It's okay.
No, they were having caviar
I'm having pizza sometimes.
It just popped into my head.
I know what Vince is having for dinner tonight.
I would like. I haven't had pizza in a long time. Actually,
you should.
It would be good, but
you should, and then you can educate your pizza delivery man.
Correct.
Okay, so I wanted to chat a little bit about schools, not colleges, but high school and elementary, because we have a nice letter from a school administrator and have a bunch of articles that we can summarize. So this is from Tim, who's from Madison, Wisconsin. He's a school administrator, not an expert. With SARS-CoV-2 being so new, we lack clear signposts about how to plan for the upcoming school year. We were closed for all but remote learning this spring after mid-March, and this emergency remote learning had many shortcomings academically, as well as negatively affecting the social and emotional well-being of many students. It placed hardships on parents and guardians who were essential workers or working from home. My apologies if you've already talked about this, but I'm hoping you can explore the state of our understanding of transmission in children and adolescents. And he quotes from the American Academy of Pediatrics in return to school considerations. They want children to go back to school. They say it's really a good way to learn. Preponderance of evidence indicates that children and adults are less likely to be symptomatic and less likely to have severe disease. And
children and adolescents.
Adolescents, and less likely to become infected and to spread infection. I have strong respect, this is now Tim, for the AAP, and over my career have found their guidance helpful, grounded in evidence, and child-centered. I share the strong desire to have children in school. But the recent stat article on the puzzle we find ourselves matches my sentiments better, but I'm not a scientist. I also likely to put more weight in preprints, like the recent Korean study on mildly symptomatic children. When you're looking for evidence to guide decision-making, it's tempting to be quick rather than patient. In the end, we'll follow the direction of our local health department, but he would like some information. So he sent a bunch of links to papers. And also this week, Trudy.
Yes, Trudy.
Ray.
Trudy Ray.
Sorry.
Wrote a blog post about infections in children. And I got
nice blog post.
Nice blog post. So I wanted to just mention a couple of these. They're quite interesting. The first one is a CDC article, which is it's in emerging infectious diseases. Viral load in mildly symptomatic and asymptomatic children with COVID-19. This is out of Korea, okay? Emerging Infectious Diseases, the journal, right? So basically, they looked at RNA by PCR and nasopharyngeal samples in 12 mildly symptomatic and asymptomatic children. They tested 12 of these kids and also saliva.
Saliva, feces,
and urine, right?
And urine. And so 92% had positive RNA in the fecal specimens, and 73% of the saliva samples were positive.
For RNA, right?
For RNA.
Okay, so that, of course, doesn't tell you about infectious virus, but these are young kids. What are the ages here?
Median...
27 days to 16 years.
Yeah.
Yes.
27 days.
Quite a range. So the swabs were positive in all children. 11 had, as Brianne said, in the fecal, and 8 had positive in the saliva. Okay.
And the symptoms, so 3 did not have symptoms, the others did, and the symptoms were pretty wide ranging.
Yeah.
So some of them are one just had a fever, one just had cough. So they're kind of things that you wouldn't necessarily be, I guess, totally abnormal for some of these kids.
I guess the point of this is that they're shedding viral RNA. All right. Now, is it virus?
Do get infected, and they
do
might be infectious if this turns out to be infectious virus and not just RNA.
So the next article from Emerging Infectious Diseases, culture-competent SARS-CoV-2 in nasopharynx of symptomatic neonates, children, and adolescents. This is out of the University of Geneva. So they actually try and isolate virus in cell culture from these kids. So they had a base of 638 patients, all less than 16 years of age. 23 were positive by PCR. And of those positives, that's 23 positives. From 12 of those, they could get infectious virus by putting the nasopharyngeal wash on cell culture, looking for CPE and RNA in the supernatant, and passaging it as well. So they got virus from children of all ages, the youngest 7 days of age. So these kids can shed virus as well. And the interesting thing is, of course, to me, that many were positive, but few had infectious virus there, right? And so, you know,
only about half had infectious virus, right?
It's very interesting that whether it's not enough for PCR or it's just not infectious, but obviously PCR alone is not giving you the whole picture, right?
Right.
The ones who had an infectious virus, though, were they symptomatic?
Some of these kids were, right?
All of the children here were symptomatic.
Yeah.
All of them. Okay.
Yeah, so all of these children were symptomatic. And these all were nasopharyngeal specimens. So you could also imagine that perhaps there were differences in sort of where in the course of disease these kids were, and whether or not they had a lot of replicating virus in that nasopharyngeal sample versus other places.
Yeah, but they didn't have the culture positive and non-culture positive, RNA positive ones. Didn't have any difference in symptoms or anything like that. They were all on the same spectrum.
So these
now, granted,
symptomatic,
it's only 23 kids total, so
course.
we're dealing with very small
right.
numbers here.
So do you think they had enough symptoms to keep them at home?
Yeah, that's a good question. Hard to know, right?
Well, it depends on the parents.
Yeah.
Ferris Bueller's parents, forget it.
So they say here, our data show that viral load at diagnosis is comparable to that of adults, and that symptomatic children of all ages shed infectious virus in early acute illness, which is, of course, a prerequisite for further transmission. Isolation of infectious virus was largely comparable with that of adults.
So, Vincent, who's going to tell the professors and teachers to go back to school?
Their employers.
The employers, you want to get paid?
No, I realize that they're going to tell them to, but they're running a very high risk of catching.
I understand,
virus.
but I do think there's a compelling argument to go back to school.
I agree with that. So can you create some kind of a barrier, a transparent barrier between?
Yes, I've seen pictures of schools in South Korea where each kid's desk has a plastic barrier.
Oh, yeah.
You know, and they're all sitting there at their individual desks, and you keep distance, 2 meters between desks, and the kids stay in the same group through the day.
Yeah.
So there are measures that can be put into place that will severely limit spread. And if you combine that with testing, which if you're not Cornell, maybe you would actually do, then you could find cases when they do arise. You could trace the contacts. Yeah. All the kids in that classroom then get tested. Anybody else pops up positive, then they get isolated as well.
Yeah.
And that could be run properly. Now, my bet is that here in the United States, some states may run that properly if we're really lucky, and a lot of states will probably not.
Yeah.
And I just, from what I've seen so far about management of this pandemic, I think it's going to vary a lot state to state and even county to county, town to town.
I could imagine it varying grade to grade as well.
Grade to grade.
I was just going to say,
think about how a kindergartner would follow these things versus
Yes.
a senior in high school.
Yes.
And the teacher as well, because the hands-on learning experience at third grade is a lot different than sophomore in high school.
It's not easy yet, because I do think face mask wearing has to be all day. And I've seen some proposals where the kids wear face masks everywhere except when they sit down, which seems
backwards.
Not a good idea.
Well, but the masks isn't going to get us out of this. I mean,
but it's an important
that's part of it. Yes,
Yeah.
absolutely. And the masks also serve as a reminder that this is not normal, and keep people from touching their faces and limit things that way. But you need these other measures too, and I think you definitely need the testing.
Definitely need testing, and this is a financial burden, especially on small school districts. The states and the Fed have to help out. We're all in this together, folks. Come on. This is life or death for many people. The other paper I wanted to mention, it's not a paper actually, it is a snapshot of research in progress to provide some information, which is cool. It should not be used to guide clinical practice. An analysis of SARS-CoV-2 viral load by patient age from Christian Drosten in Germany and a couple of other countries. And so very interesting, 3,300 patients who were tested positive for SARS-CoV-2, and they wanted to say, what's the relationship between their age and the estimated load by PCR? And they had two different PCR systems in this study. One, the Roche LightCycler 482, viral loads did not differ significantly in 3 comparisons between young and old age groups. Then there was another analysis done with a different system, the Roche Cobas 6800/8800. Are you taking notes, everybody listening?
No.
I commit that to memory.
They said they showed a credible but small difference between young and old. And they think this difference is all about PCR instrumentation. All right. So they don't think these differences are of any relevance. So they think there's little evidence from this study to support suggestions that children may not be as infectious as adults. Now, to be fair, in Trudy's article, she does cite one study where they find very little shedding from kids. But here we have 3 that we just talk about where we have shedding. We obviously need more, but of course they're limited because schools are out, so we don't know what's going on.
And the other side of this, so these are analyses at the patient level, looking and showing that yes, kids can get infected. They can produce infectious virus. Yep. They seem to do it maybe at levels that are about the same as adults. But then when we look at the epidemiology data and the epidemiology models that people have done, it's very hard to find evidence that schools played a significant role in the spread. And that's kind of striking because it's just weird to me that a respiratory virus is not blatantly being spread by the schools. I mean, everything we know about, or everything from measles to flu is that if it's spread by a respiratory route or fecal oral route, it's going to be through the schools, and kids are great at this. And it may not be as bad with this virus as it is with some of the others, and that's certainly worth watching.
Tim had sent, sorry, one moment, Dixon. Tim had sent actually an interesting article which suggests that it's about influenza and how social contact networks influence the spread of respiratory infections. And it suggests that high school students have wider networks and so greater mixing compared to younger children and may have greater potential. And that's really interesting, right? The social aspect of it, which we often don't think about, but that can make a big difference, right?
Yeah.
So,
right.
Yeah. And it may be that the normal spread that we see, schools being very great incubators for things like influenza, it might be driven more by extracurricular stuff and the lunchroom than it is by having kids in the classroom. Yeah. Kids in the classroom, they're all facing the same way for the most part and interacting with the teacher. Whereas in social settings, they're standing 2 feet apart and talking to each other and so forth. And that's a lot more like the parties or bars type of setting that we see these super spreader events in.
Yeah, I think that many of the daycare centers and schools that did stay open took a lot of these types of precautions.
Yes.
And so while they stayed open, they weren't doing sort of business as usual.
Yeah.
And so maybe that's evidence that the lack of spread is actually evidence that those types of precautions
those measures
really effective.
Work. Yeah.
Your comment is a good one, Brianne. The bus. And
the bus.
The bus is a dangerous place. I have a couple of comments about the.
God, did I hate the bus?
I have a couple of comments about the assays for infectivity. I'm suspicious that the sensitivity threshold for these assays is I don't know how to say high or low, but they're not very sensitive. First of all, we've never talked about exactly technically how these are done. This is not go in and titer the virus. This is go in and take a sample and stick it into a well in culture, leave it there for a little while, and then come back and ask whether there is a cytopathic effect. That is, whether the cells get sick, whether they get visibly sick. Mm-hmm. So that does not quantify whatever virus you have. It just says if there is something there or if there is not. And the paper that we did a while ago assayed quite a number of symptomatic individuals. And I recall, Vincent, it was only 25 or 30% of those that they got positive virus culture out of. That, of course, correlated, not of course, but it correlated with the RNA load.
That's right.
If you had a higher RNA load, the higher the probability was getting live virus out. But I'm not convinced that 75% of people who have symptoms and have virus load are don't have infectious virus. It makes me suspicious that, and I'm not faulting anybody, it's just hard to do.
Yeah.
I'm suspicious that the tests are not really sensitive enough. And so I would, in my mind, I have that going on as I...
so there could even be more virus positive kids.
Yeah. And I agree completely, Rich. I think the other thing that comes to me about that is the location of sampling, that we're not looking at all different parts of the lung. We're only looking, for example, in the nose or something like that.
Yeah, for sure.
Yeah, and who's assaying the farts?
Yeah, right.
You're missing a whole thing.
Right.
So
so I think we've got two types of tests. There's the infectious virus test and the PCR test, and one is probably not sensitive enough, and one is definitely too sensitive.
Yeah.
And you can't just average them. So we're getting a lot of people who are RNA positive for weeks and weeks after infection, and I'm just sure there's no live virus in there, active virus in there.
For sure.
And then you've got people who are positive for RNA and they're coughing up a storm, and they're negative for infectious virus, and I bet there's infectious virus.
But even though it's likely the long-term shedders are not shedding infectious virus, you need to be sure, because clinicians are going to make decisions, and you could backfire depending.
Yes.
Oh, yes, you can go back to the nursing home and then they infect people. In this Drosten paper, they say the combined data from PCR and both PCR instruments show that viral loads have at least 250,000 copies, a threshold we previously established for isolation of infectious virus in cell culture at more than 5% probability were present across the study period, and 29% of kindergarten-age patients 0 to 6 years old, 37% 0 to 19, and 51% above 20. So it does seem to go up, interestingly. Yeah. So the bottom line here... go ahead.
I have family in the business. My son-in-law is a elementary school principal. And my daughter actually has just now acquired the position of interim chair of her theater department at Texas State.
Oh.
And so
congratulations.
I can tell you that Texas State they're planning on going back to school and limiting class sizes. And I believe everybody's wearing masks. And yes, masks and provisions in the dormitories for quarantining people should that necessity arise. And they have a whole bunch of contingency plans. I don't know anything about, I'm not sure about testing. And that's really a no information from me. Doesn't mean there isn't information there. And in terms of the elementary school, I think they're looking at a number of options, and they haven't. They have a number of contingency plans, and I don't think they've come up with a final solution at this yet. But of course, everybody's doing the best they can and looking hard at it.
So in situations where they didn't close the schools and where children and young adults were still allowed to go to class, what was the rate of infection in the professoriate, so to speak? How many teachers actually got sick from this and had to stay out of school for a prolonged? We don't know the answer to that.
I think that's a good study that could be done.
Yeah.
You got the data. The data is all there.
And also, Dixon, I think you might want to get a job as an elementary school teacher this semester.
You think? It's way above my pay scale.
So the bottom line here is, to summarize, someone criticized on YouTube the other day, it took you 2 hours to get to the point.
Really?
I mean,
just 2 hours?
That person was not a long-time listener of ours.
2 hours to get to the point. There's not just one point. There's not just one point. Okay.
So I wanted to say one thing about the protests that were held 2 weeks ago. Almost no spikes in any city were correlated with the outdoor protests for Black Lives Matter. So, and wearing masks were optional, of course. And in some cities, they had a lot of mask wearing, and some they didn't. So, and they were all screaming at the top of their lungs, I would say, to be heard. I'm not criticizing that at all, but that's so the droplet factor must have been very high, and still there was no significant peak. So that says something about
and I would point out
dynamics
that
this.
there's no okay, so we're talking about there's no documented transmission. It could have happened, but we don't have any obvious events where that happened. With either the Black Lives Matter protests or the earlier protests that occurred where people were protesting their right to get a haircut, which I don't support those. I think that was a silly, but it's not up to me to decide who gets to protest and who doesn't. So yeah, it's your civic right to go out and protest. And I think the encouraging information here is you can exercise that right safely and not be at risk the way you would be if you went out to a bar.
Correct.
Right.
And if you're protesting for your right to go, if you're protesting for your right to go out to a bar, you're safer at the protest than when you finally get that right. So just,
here. So
at least from the data we have.
So the bottom line for this is that kids should go back to school. They're likely shedding virus. They're likely transmitting. We don't have a perfect answer yet, but it doesn't matter. You still need to be careful. You need to do testing, face masking, distancing, plexiglass shielding, whatever you can do. You need to do it.
Limit the lunchroom. Think about recess.
Oh, did you see the thing from Kathy she sent this morning? Oh, she sent it to me. This is brilliant. I have to read this. This is like a humor piece. Here. This is great. She sent it to me at 6 a.m. and I was having breakfast. I said, "Oh, you can't sleep either, huh?"
And you're reading your email at breakfast. Good for you.
Not a good idea. I know.
No,
I try not to because it can annoy me.
I keep confiscating my daughter's screens when she's eating. And
so this is in McSweeney's, right? It's called A Message from Your University's Vice President for Magical Thinking.
Oh, I think I might have seen it.
Dear university community, here's our strategy. After measuring classrooms and examining our antiquated ventilation, our staff, those who haven't been furloughed, reports that there's absolutely no way our already scheduled and enrolled classes can safely fit in those spaces. But our university has always valued creative problem solving, so we have posted "No COVID-19 allowed past this point" signs on the doors of every building. Plus, to show how seriously we take the situation, the signs have been laminated. And it goes on. It's just like, isn't that great? Thank you, Kathy. And Kathy also, yes,
but
go ahead.
Kudos to the American Academy of Pediatrics, by the way, because with their statement taking a strong stance on yes, schools should open. And I know how organizations like that work, and I know that this was a fraught conversation. And they make a compelling argument that there's a lot that schools provide that you can't get elsewhere, and there's a lot of child health that comes from going to school, and parent health. Weighing that against the risks. Yeah, this makes sense, and we'll see how it goes.
And this is a really complicated thing.
Yeah,
a very complicated thing.
Daniel mentioned all these things when we talked earlier. Yeah,
because I have a lot of friends who are thinking about what to do for their particular family situation, and it's hard. We're not saying that, there's a cut and dry answer here, because it's really challenging.
But you're right, Alan, about the AAP, but they tried to use the excuse of they don't transmit as much, and I don't think they needed to do that.
Well, they couched it kind of carefully.
Yeah, they shouldn't do that.
The evidence we have is that maybe they won't transmit as much.
Yeah, but that's not right, because then
but
you
they're
have
also,
people like
but
Tim.
At the same time, they are advocating, it's not going to be just go back to school. It's got to be different. You've got to handle things differently. And I think the conversations that are going on at the most state levels are along those lines.
Kathy, also
for the YouTube listener who wants us to get to the point, the point on TWiV is that the journey is every bit as important as the destination.
Yes.
So I imagine myself teaching a let's say a high school class, and you come time to give an exam.
Mm-hmm.
All right. So even if you gave that exam, well, you can't give it online. I think giving it online means that everybody can go home and look up the answers. So you have to hand out sheets of paper. People sit down, they write things, then they have to collect them. This just brings people together in a way which we're totally used to, but in this case, you're going to have to figure out a different way of doing that.
Yeah, leave your exam paper on the desk, and teacher comes around and collects it when you leave the room.
Cool.
And there are ways you can do
it
online.
No, but it alters the pattern of virtually every mechanical part of teaching.
Just let me point out, Dixon, you can do online testing and restrict students from leaving and going to another site. There's software, as Brianne knows, testing software. When they leave the site, there's an alert, or they can't leave the site, and so it can work. All right.
You can also construct an exam that is structured so that
Google proof.
It doesn't matter if you go online.
Yeah, if you spend all your time trying to look stuff up, you're not going to be able to finish.
That's right. Yeah. You got to put a time limit on it. Yeah.
Yeah. If I make up an exam that has a made up pathogen with a list of criteria that I indicate, the students are not going to be able to Google information about that pathogen.
Yeah, for sure.
Okay.
So Kathy sent us from her brother, Bill, this article, coronavirus, phone ahead when you need treatment at A&E, accident emergency. Patient will be asked to call ahead and book an appointment before heading to the emergency department. Oh my gosh. So how can you do that if you're in an accident and, right? So I guess this is crazy.
It's just a flesh wound.
Well,
I plan to drive unsafely.
I think it goes hand in hand with the drive-in liquor store.
This is the problem that we've been talking about with flattening the curve. Okay, the whole idea is to keep the disease sufficiently at bay so that the healthcare system isn't overwhelmed. Because if it becomes overwhelmed, you run into a situation where people aren't getting the care they need, not only for this but for other things as well.
Right.
By the way, guys, Daniel said to us earlier that his hospital, for the first time since February, has 0 COVID cases.
Wow.
That is amazing.
Isn't that incredible?
Amazing.
Yeah.
All right, let's do some email. Alan, can you take that first one?
Let's see. So,
Josh.
Josh. Hello, TWivers. I'm only an engineer and have been listening to your podcast since March 2020. I'm listening to 634 and the discussion around the G4 influenza strain found in pig surveillance. My first question is it possible to tailor a vaccine or a vaccination strategy in pigs to direct the genetic drift away from efficient reproduction in humans or efficient between humans? Seems like stopping the next zoonotic origin pandemic in the original host before crossing over to humans would be optimal. I assume that implementing this would be much easier to do in farmed pigs rather than bats. Are influenza strains that are optimized for transmission in pigs necessarily less optimized for infecting humans? I would guess not, but I wonder if it's possible to outcompete a swine influenza with a less deadly but more transmissible strain that results in immunity to the strains that can jump to humans. Temperature here in Rochester is 76 Fahrenheit with 63% humidity and an effective reproductive rate of 1, according to this would be the 400 level course in vaccine development. I think these are very cool ideas that would be very hard to do with our current technology, but I think it would be awesome if we could get to a point where we would detect stuff and prevent it from making the spillover.
Yeah, I agree that it would be easier in farmed pigs rather than bats.
Yes.
So we do immunize pigs, but the question
I was wondering,
is,
do we immunize for flu?
Yeah, we do. And well, not me, but they do. Right. And the question is now, should they make a vaccine against this? Because we don't actually know if it will end up in people or not. But I assume if it is in enough pigs and it's a threat, they will incorporate it into the vaccine. That would be a good way to prevent it from getting into people. And you don't have to do this fancy thing of directing the genetic drift, which would be quite challenging, I think.
Yes.
However, I was thinking, can we, pigs are born and then they get infected from the rest of the herd, from the human handlers. Is there any way to stop them? They're all inside biologically contained piggeries, right? But still, the humans go in and get close to them.
The country.
Depends on the country.
You bet.
Well, you got to go in and take care of the pigs, don't you, Dixon?
Yeah, but in China, it's a little bit, about 60%. I guess we learned that 60% of all the pigs in China are being raised indoors. Unfortunately, most of their pigs just died from African swine flu.
Yes.
Fever.
So they're importing pigs from the United States to China, basically.
Anyway, I'm talking about something I know nothing about, pig farming. So I think vaccination
Piggery sounds a lot better than sty, I have to say.
That's what they call it in Singapore and Malaysia, piggeries.
Piggeries, yeah, that's right.
I think vaccination for the moment is the key. Rich, can you take the next one?
Mike writes, "Hi, Twivers. It's oh wow, here's a new one. It's it's 551 degrees Rankine here in South Florida. What's Rankine? Do you know?
That is
No idea.
It's like Kelvin but in Fahrenheit.
Oh.
So if you calibrate the Fahrenheit scale to absolute 0 but use the same size degrees, then you get Rankine.
Whoa! Somebody's got too much time on their hands. Your reporting, I guess Rankine has too much time in his hands. Your reporting was a bit out of date. Airline rules vary by airline, but mask wearing enforcement has stepped up across most airlines. Here are the rules at my airline as I understand them. All customers must wear masks at all times on the aircraft unless eating, drinking. My airline will warn you once if you take your mask off. If you continue not to wear a mask, we will put you on a list of people who are not allowed to fly. You are correct. It's impossible to enforce the rule on a particular flight. An escalation to a physical altercation on the flight is probably less safe than someone willfully disobeying the mask requirement. But we will not let a person who will not comply with mask requirements fly again on the airline. Very interesting. Only some airlines are not mask wearing is the equivalent of being a terrorist, I guess. Yes. Some airlines, only some airlines are selling full airplanes. Currently United and American. Other airlines such as Delta and JetBlue are still leaving open seats to help with physical distancing. All airlines are continuing to evaluate this, and it might change in the future. Airlines have some of the best air circulation you might encounter. Generally, the airflow is from your head towards your feet. Most of the air is fresh air from outside the plane. This air is heated up to around 200 Celsius due to compression before being cooled and introduced to the cabin. The recirculated air is, 200 C.
It's hot air.
That's hot air.
Well, if you're at 30,000 feet and you're compressing that air to to a cabin altitude of 5,000 or whatever, that's a lot of air compression.
The recirculated air is passed through HEPA filtration, 99.97 of 0.3 micron particles before coming back into the cabin. According to the EPA, the 0.3 micron particle size is the worst case scenario. Larger and smaller particles are filtered even more efficiently, and gives a reference, Michael. And Michael is a captain on the A320 aircraft at JetBlue, speaking for himself and not behalf of his employer. What a cool airplane. Such a cool airplane. And that's great information. People talk about recirculating air. They wonder how much comes in from outside and all of that. And this is a really nice summary where the airlines are at. I really appreciate that.
Yeah.
But this, nevertheless, during SARS-1, there was clearly a transmission on an airplane. Yeah. Remember last time we saw the picture of the plane, and I don't know if technology has improved since then. It might have, but if someone is breathing right next to you, doesn't matter how much HEPA filtration you have, right? This probably limits the circulation throughout the whole plane of air droplets, right?
Yeah, but it is a common misconception, I think, that there's a lot of recirculation of air in an aircraft, and people flip out about the idea that it's being recirculated all over the place.
Yeah, he says most of the air, yeah.
Yeah.
It's a lot. That's a good point.
Most of the air is fresh and it's HEPA filtered. Huh. Okay. And from the SARS-1 data that we have, it looks like what transmission does occur is pretty local.
Yeah.
Okay, which also supports the notion that it's not virus being recirculated all over the aircraft.
I wonder, hey, Alan, do you know how this is compressed? Do they have pumps that are doing this?
I don't know how it's done. It's probably either an engine-driven pump or a like compressor or something like that.
Interesting.
And is this cool? We've got a JetBlue Airbus captain.
It's cool.
Listening to TWiV.
Yes.
Thank you very much. That's awesome.
We've heard from other, maybe Mike or maybe another airline captain as well.
Yep.
We heard from one who was furloughed, who was.
We had one in like February who flew the Singapore route.
Yes.
He said, I used to fly the Singapore.
Yeah.
Right. Used to fly the Singapore route. Yeah. So flying on an airliner is still not exactly going to be low risk for infection, but it's like most things, I would say it's safer than going to a bar or a party.
Safer than going to a bar.
Rich Condit, if you were sitting on a plane and the person next to you ripped off their mask, said, I'm not wearing this anymore, what would you do?
Wow. I'd have a conversation with that person, I think.
Could open a window.
I'd either that or I'd move.
Yeah,
okay.
That's what I would do.
Sometimes you can't move.
I think I would ask them to please put on their mask, and I might pull cred on them after a while. Tell them I know what I'm talking about.
Okay. Isn't it sad though?
I might even call them a mask hole.
Oh, then you get into a fight. Okay, that's no good.
Right.
Which obviously happens on planes. People get in fights, right?
Yeah,
absolutely.
Absolutely.
Isn't that horrible?
Your risk of transmission in a fight goes way up. I would expect.
It's true. This is true.
Dixon, can you take the next one, please?
I would be happy to. Janelle writes, "Hi, all. Love the show, only found it this year. My background is in the maths and physical science. For some reason, I've discovered a need to catch up on microbiology this year, and I've been an avid listener over the last few months. I finally have something I can be pedantic about. In TWiV 631, someone, Rich, I think, said that Canada follows the Queen of England. They don't. The head of state of Canada is the Queen of Canada, just like the head of state of my country is the Queen of Australia. It's just that these roles happen to be held by someone who also happens to be the Queen of Great Britain. Each country has its own copy of the Act of Secession, but at the moment they are identical, so each crown follows to the same person. I currently work for the Australian Parliament, and it's something people get picky about at my workplace. We aren't led by the Queen of England, and Canada isn't either. Janelle. Take that, Richard.
Yeah, this is
that is a wonderfully British Commonwealth way.
Sounds like Winston Churchill talking almost.
Yeah, and I think it fits right into the whole TWiV pedantic.
It's wonderful.
Yes,
That is
wonderful.
It's
beautiful.
It's wonderful.
Beautiful.
Brianne.
Braden writes, Dear TWiV team, I'm a new listener thanks to Ginger from Brain Science recommending you in response to the pandemic. In your episode 629, I caught a reference to a Zimbabwean population and your surprise over the median age of people in the dataset. I'm Zimbabwean and still resident here. Firstly, it's exceptionally hard to get accurate statistics because of several factors, including a lack of canvassing census data, technology, and integrity among politicians and civil servants. For example, I'm trying to collect a data set to do chaos analysis on, and even funeral homes and life insurance companies aren't responding to my queries for longitudinal death rate data. Secondly, yes, we do have a very low life expectancy here. At the ripe old age of 36, I've exceeded average life expectancy. Factors include HIV/AIDS infection and the lack of treatment, political violence, and high rates of traffic accidents. Thank you for keeping me informed with the latest on SARS-CoV-2. Best, Braden.
Yeah, I want to thank Ginger, who does the Brain Science podcast, and she wrote a while ago and said she had inserted at the beginning of every one of her podcasts automatically telling people, go listen to TWiV for more information about COVID-19. And, and her podcast is extremely popular. It's very high up on the science podcast there.
Thanks, Ginger.
Well, so
Thank you,
really,
Ginger.
we appreciate it, Ginger. And I'm sorry, you had asked questions about transmission. I'm sorry we didn't get to it yet, but there are many years left in this outbreak.
It'll take us some. We've got plenty of emails to read. I'm sure we'll get to hers eventually in these 137 pages.
And there are another 5,000 plus viruses that we know about out there.
Yes. We will eventually talk about them too. Stick around.
And then there are all the ones we don't know about.
Yeah.
Yes.
Right.
Michael writes, politics and virology. There may never have been a better example in human history than the role a country's politics and its political, economic ideologies play in the spread of an epidemic and a pandemic than what is going on in the United States right now. A country's political system should be an integral part of the modeling data used to project the spread of infectious disease. That's quite interesting. It's a sad and dangerous precedent being set by the Republicans and capitalists that assumes science and politics do not affect each other. While there is no scientific data to support my assertion, I think it obvious a study would bear out my hypothesis.
I think a study would be great. And it makes me think of...
How would you do that, Seti?
Yeah, I don't know. Well, I've already seen a lot of stuff that I don't know how credible it is that tries to track infection rates and stuff in what they call red states and what they call blue states.
Sure.
But, you know, I'm
the number of
suspicious
confounding
of a lot of that
factors
stuff.
there is ridiculous.
Yeah.
That would be very, very hard to tease.
However, this does make me think of the comment that I brought up the other day by my public health friend who said that public health, by definition, is a mashup of science and politics.
Yes.
And so the politics is going to affect the public health.
Yes.
I mean, it's just by definition.
Yes,
true.
The problem arises when the politicians don't listen to the public health people and the scientists, right? And I'm reminded of what happened a month ago.
That's pretty much modern history.
Yes. I'm being idealistic. Well, a month ago, Tony Fauci said this is going to get worse. We need to hunker down more. And the president and vice president said, we disagree. And I was like, what on what basis? Did you read anything? You know, if you look at the data and read papers and you say, okay, this is the reason I'm disagreeing, but they didn't. They just disagreed politically. So that's the problem that arises. Alan, you're next.
Okay, Alex writes, hello, Vincent et al. The following study points to a relatively tiny benefit to a fairly large-scale testing for SARS-CoV-2 when compared to other public health interventions. What are your comments? Alex is in Enterprise, Ontario at 30 Celsius. And this article, how widespread was the testing? I didn't get to this one.
5%. They're testing 5%.
Oh.
That's not widespread.
No.
That's the problem here. And so it's a modeling study.
Okay.
Where they test 5% of the population each week, and that's not good enough.
No.
That's why they show no benefit.
If you're doing random testing, you've got to have a much larger sample or a much better sample. I personally am not sure that truly random testing is what we need.
Yeah.
I think we need repeated testing of people who have known exposures, and we need testing of anybody who has any kind of symptoms.
Yep.
So that's what we need, and that's going to be. It may end up being 5% of the population, but you need to select them on the basis of criteria like exposures and symptoms, and then test everybody they've had contact with if they come up positive.
Maybe even testing those people who have a lot of contacts, like the people who work at the grocery store.
Yeah, that's what I mean. That's what I would call.
That's
what I would call a risk group that you would stratify and say, okay, you're going to be tested weekly because you're a grocery clerk or you work around people.
Yeah, front-facing people, fire, police, healthcare workers, etc. Yeah. Rich, you're next.
Robert writes, a retired country doctor's perspective. I guess that's the title of the email.
Yeah.
Subject of the email. Dear Dr. Racaniello and TWiV crew, I'm a retired family medicine physician within a few months of the same age as Dr. Racaniello. In other words, he's really old.
Yeah.
I discovered, in quotes, your podcast a couple of months ago at the beginning of the current pandemic when it became a patriotic act to stay home, which I've been doing. In early February, I told a group of friends that this would be a big deal, and they all thought I was nuts. Several have apologized to me since since then for my predictions of doom. My family listened, however, and prepared for the problems, as did I. I recently donated blood and was tested for antibodies for which I was negative. Please allow me to opine on several comments from the most recent posting, TWiV 632 and other things. 1, of course, I have all the time in the world. I listen to your podcast daily, TWiV, TWIM, TWiVO, TWIP. I walk my dog several times a day, further than she and I need to do her business, which is good for us and allows me time to listen to your podcast. They are most entertaining. I love the banter among friends. Yeah, I love the puns. Keep it up. I have to admit, I'm somewhat afraid to go to the gym where nobody but me and the staff wear masks. I'm certain I'm the only one who breathes hard. 2, I agree politicians should not opine on the science, especially those who claim to lead this country who don't listen to their advisors. 3, I've often told folks that I am not a scientist. I am a technician with scientific training. I have tried to keep up over the years, especially evidence-based medicine, which I will agree with Dr. Griffin was often opposed by the old guys when I was in training in the 70s. 4, your correspondents mentioned death rates in several countries like Iceland, where the death rate was low, allegedly due to the low-carb diet. This is an imprecise use of the term death rate. The death rate overall is 1. With the exception of a few believers in specific religions, nobody gets out of this world alive. If you don't die from heart disease, you will eventually die from something else. It was pointed out to me that although a third of people who smoke die from tobacco-related illness, the other 2/3 die from something else. This is not cynical, it's a fact. When one cites death statistics, one should, if claiming to be scientific, to be specific about what one means. Do you mean excess deaths? And compared to what and at what ages? If you want to be pedantic, which I have been all my life, you have to be specific. Thank you for the tremendous podcast. Robert, who is an MD. All right, a little bit of pedantry there.
Okay.
Appreciate that.
That last point is really good, this idea of excess deaths, because in this book by Raul, which I was looking at breakfast before I started to look at my email, unfortunately, he talks about the use of the excess death, and he has a graph from Spain, which shows, here it is, excess mortality from January to April. Okay, so you see that curve?
Yep.
So the blue is normally, and the red it was this year.
Yeah.
So you can see there's an excess death, and that's what we should talk about. He says the reason you use this is because sometimes people die and you don't know that what the cause is, if it's SARS-CoV-2 or something else. So yes, that's really a good point.
I love it. The death rate overall is 1.
It's good.
That's it.
Yes.
It means all of us are going to die, right?
I'm afraid so.
I'm kind of hoping an exception is going to be made in my case.
Really? You want to live forever?
No. I'll be happy with 100.
Okay. Oh, well, okay. If you row every day, you might make it.
Yeah.
I'm going for it.
It's true.
Dixon.
Yes. Bill writes, Dear Vincent and all, in British Columbia, we have done well to control the spread. We have had 148 deaths in a population of about 5 million. Here are a few of the things we've done. The border with the U.S. is closed.
That helps.
That's a good start. We have enough tests that anyone who wants one can get one. We have locked things down quite a bit. We have a well-run comprehensive program to isolate all who test positive and to trace the contacts of all positive cases. The single key thing the provincial government did well was to put the medical health officer in charge of the pandemic response. The government then energetically followed her lead. Here is a link to an article about this. The other key thing we did, mostly all citizens took it seriously, and it was our responsibility to protect ourselves and our fellow citizens. And
not complicated.
No, it's pretty straightforward, but you have to come on board and you have to agree.
This part about following her lead. I mean,
you can't be an anarchist.
This would be like following Tony Fauci's lead, right?
Or, yeah, that's right.
It would be like
that's exactly right.
It would be like having the right people in charge of the CDC and following their lead. That's supposed to be the lead agency on this. There's an actual procedure set up for the government to follow, and
so CDC is supposed to lead in outbreaks, right?
CDC is supposed to lead in an outbreak, and they completely dropped the ball. And Tony Fauci's doing a great job,
but it's not his job,
he's not
right?
supposed to be the guy. He's supposed to be the research guy.
I see.
It's supposed to be the CDC that's taking the lead on this because they've got the epidemiologists and the expertise that is built for this. And here we are.
All right. Brianne, you're next.
Debbie writes, a loved one fell ill for 2 weeks. Severe headaches, fatigue, loss of taste, smell. Teleconference doc said yes to COVID-19 as diagnosis. About 2 weeks in, she got the swab, but proved negative, faulty test. This week, antibody test showed 2 antibodies, short and long term. I guess that's IgM and IgG.
Probably.
Were indeed detected. Question. At this juncture, would this individual still be susceptible to catching COVID-19? Could this individual carry the virus and pass it on? Or is there any evidence to suggest that because of the presence of antibodies, this individual has some immunity and therefore cannot pass the virus along to others?
Brianne, this is like one of your exam questions.
There you go, Brianne.
It is.
You sent me.
Look this up.
You sent me some of your questions, and this is one of them. Paul and Mary and John have this IgM and IgG.
Yep. Yes. So the fact that this individual has some antibodies says that they do have some immunity. We don't have great evidence right now on what types of immunity are protective. And so I can't say that the person is definitely unable to carry the virus, or definitely protected from the virus. Basic immunology kind of suggests that they might be, but in this case, things have come up that have been a little bit off. And so I'm not certain, but they do have some immunity. This is also one of the pizza questions.
Didn't we do an email last time, Brianne, of someone who, let's see, how did it work? He was seropositive, and his son got infected, and he didn't set distance or anything because he figured he was immune, and then he got infected actually, or something like that. I thought that was on our last TWiV.
I don't remember that one.
No? What am I thinking of? Another podcast? No, I haven't.
Maybe it was your examination.
Anyway, yeah.
There is a neat paper that's about to come out from Columbia, actually, that looks at patients with varying levels, varying degrees of disease. They were all hospitalized, but like really severe patients on ventilators versus patients who were just in the hospital, and looks at antibody levels. And it's got some, I can't go into detail because it's under embargo, but it's some very cool analysis of what's going on. And it looks like this is going to turn into one of these complicated, nuanced immunology stories that Brianne is going to be all over. And it's very interesting, but it's not going to be conducive to easy answers to a question like this.
Right. So in one way, I look at this letter and I think, oh, I would like to look at this individual's T-cell responses.
Yes.
Yeah, sure.
And since we've been talking about this, a friend of mine from graduate school sent me a preprint that he is an author on. I have not yet had a chance to read it. That's on the docket for this weekend. But it seems to indicate that perhaps a sort of atypical type of B-cell is really important in the SARS-CoV-2 response. So I've got to take a look at that.
Brianne, order up a pizza, sit down, and read the paper.
Read the paper.
Make sure it comes with gamma delta T cells.
So, wait a
By the way,
minute.
was that discussion about the pizza delivery in the show, or was that?
No, I don't think so. I
that was
think
before we
people
started
need to-
recording.
Yeah, that was in Slack or something like that.
Yes.
Yes.
Well, and also just now before we started recording, before Rich signed in, we were talking with Brianna.
Ah, okay.
Oh, you
yes.
could still have a pizza anyway and read the paper.
I could have a pizza anyway. Yes, the short version is that a pizza delivery person recognized my name and asked me COVID questions before they would give me my pizza earlier this week.
And then they graded her on the answers.
This is the price of fame, Brianne.
There you go.
That's right. That's right.
Mark writes, can you set the record straight that there is almost zero chance of being infected by a fleeting biker or runner or even walker passing by outside on the street or in a park? It's just awful watching people scurry to a side or angrily glare out at you out of mass hysteria induced by politicians and the media. You're not contracting coronavirus outdoors in low-density settings. Buses, subways, crowds, sure, that's a different story, but a beach on a sunny, humid day, it's zero. Let's restore at least a modicum of sanity. Mark is a CEO of a big company. I don't think we can say there's zero chance.
I wouldn't say zero.
Of anything. I do think it's less outdoors because, as we have heard from many, like the protests, right? No outbreaks as a consequence. And certainly, yes, indoors are much, much higher.
Perhaps we should change mass hysteria to mask hysteria.
Well, yeah, I mean, Mark, I understand where you're coming from, but I would shy away from making strong statements about this based on the data that we have. It implies that outdoors is safer than indoors. It implies that probably the runner going past you is not going to be high risk, but maybe people are having some kind of extreme reactions, but I think that's on them and you should just ignore them.
Isn't the real situation when you're standing in front of someone for a period of time, 10, 15 minutes, that's the transmission?
Probably
not just
and
going by, right?
Right. The events that we have that we're able to document exposures for are people talking to each other and direct interactions and things like that mostly. But I wouldn't say somebody's at zero risk from a jogger going by. No. And
but it's very low. As Alan would say, this is a low risk activity.
Right? This should be a low risk activity, but I wouldn't take extreme stances on it.
Well, you never know if that person on the sidewalk who's being passed by a jogger might be at high risk for some other reason and feel uncomfortable.
So we're all evidence-based scientists here. There's no evidence, so how can you possibly say anything?
Well, but we're okay. Period. So there's no evidence, but we have to make decisions in a vacuum of evidence because it's a real situation. And so we look at the evidence and we say, nothing's no risk, but this is probably low risk, and cut a little slack to the people who are paranoid about it because. Yeah, it is a scary virus, especially if you're in a high-risk group.
How would you feel about being in charge of a marathon?
Oh no, that'd be the easiest job in the world right now. The only question is, do you spell canceled with one L or two?
Right, that's true.
Real simple job.
No audience, just runners.
That makes me think about
relatively
early on in this, in early March, Austin canceled South by Southwest.
Yep.
And there was a lot of hand-wringing over that, but in retrospect, that was a good call.
That's a good call. Alan, you're next.
Okay. Todd is asking about the multi-system inflammatory syndrome in children. Is that a cytokine storm, or is it something related, or is it something new or rare? Yes, it could be all of those things. So this it links to the Times article, and this is an inflammatory syndrome that's been seen in some kids. It seems to be quite rare, but that's not really comforting to the kids who develop it because it seems to be quite serious. And I guess Daniel's talked about this. And it's
so is Peter Hotez.
There are some similarities to another condition called Kawasaki disease that's been it's been studied for a long time especially in Japan, and that has had some tantalizing links to a few different things, but not. There are some data that it may be on fungi that are spread through an airborne route that. Seasonally, there's a seasonality to Kawasaki disease that induces this inflammatory response in some kids. But because it's rare and because it's a complex immune response, it's been very, very hard sort that out. Is it a cytokine storm?
Apparently, Kathy asked a pediatric ID doc for us there.
Yes. So, and that's the highlighted part here?
It's under the purple there, which...
Under the purple, yes.
I guess it's...
Yes, the general thought is that it's a dysregulated post-infectious hyperinflammatory state that occurs sometime after SARS-CoV-2 infection, i.e. not during acute infection. Many cytokines and other inflammatory mediators seem to be increased. There are similarities to Kawasaki disease, a well-known but uncommon inflammatory condition in children that seems to be caused by infection, but has yet to be linked to a specific pathogen. Okay, yeah, I could have just read this. However, the syndrome that's being described now doesn't seem to be completely identical to Kawasaki disease. So it's potentially something new, probably rare in terms of not happening in every child who's infected with SARS-CoV-2, but new enough that the epidemiology is not yet well defined, and then links to the CDC description of it. And there was a webinar about it May 20th. And is that accessible? I've got an event registration page.
I also just put in 2 links to papers that have come out really recently that were perspectives on what is a cytokine storm. One of which includes the sentence, cytokine storm has no definition, but tries to generally talk about what immunologists are describing when they mean a cytokine storm, which cytokines are important, and what exactly is going on there.
So maybe we could write the second childhood book, Cloudy with a Chance of Meatballs, in this case, Cloudy with a Chance of IL-6.
Rich,
because it's a storm, obviously.
Yes, I got it.
Yeah.
Rich, can you take the next one?
John writes, love the show. This is a fascinating narrative of flying back to China with lots of pictures and details. And he gives a link. And this is a link to I guess it's a blog. Oh, it's a newsletter from an organization, I guess, or an individual, Sam TWiV, and it's on aviation and travel. It's dated March 26th, and it's basically a diary, a journal of an individual who I guess was studying in the U.S., but whose home is in China, and says that at the time of this writing, the total number of confirmed COVID-19 cases in the U.S. skyrocketed to over 54,000. So we do that every day now.
Yeah.
With no sign of stopping. At any rate,
piece of cake.
This individual decided it was time to go home and has a nice sort of journal with a lot of photographs of what that trip was like. It was complicated even to put together a flight. And there's lots of interesting pictures of deserted airports and other deserted airplanes and other.
It looks to me like it helped a lot that this person is a frequent flyer who's got all the platinum rewards program and was able to get business class upgrades, which would make a huge difference in distancing.
But he went from JFK, Chicago, L.A., Honolulu, Guam, KIX to Peking, Beijing.
This is like the flight you would have taken in the Pan Am Clipper days.
Man, so many, because he couldn't get
in Guam for refueling now.
He could not get a direct flight. So, wow, that's really something. Thank you. Dixon.
Alina writes, hi, I love TWiV and listen to every episode now, no matter how long and no matter whether it's about SARS-CoV-2 and COVID-19 or something else. Thanks for all the amazing info. I work in public policy for Canadian Province's Ministry of Health. For years, we, like other health partners, or planners rather, have been obsessed with the impact of an aging population on our healthcare systems. Lately, I've been wondering what the probability is that this pandemic could radically reshape the population age profiles of Western countries. What do you guys think? Thanks, and keep making nerddom great again.
Wonderful.
Thanks, Alina. Well, it's not just the older people who are being affected, but it's also disproportionately, at least in terms of population distribution, African American, people of color, people living in less than middle class conditions, that are being affected more than others. So I think in those populations, the age profile of those populations will definitely change a lot over the next 10 years, let's say, maybe have already. Now, the same might be true in other countries where the ethnicities are a little more homogeneous, like Italy or Spain, where the older people in those countries were also dying from this. And of course, the people in all of the nursing homes. So those are the real targets for this, for increasing this big curve that Vincent showed before, with the overkill, so to speak, from this. So
if this gets through, if this rips through, although it's going to take a while, 50,000 cases a day in the U.S., it's going to take 10 years for it to infect everyone. So we'll have a vaccine before then. So, I mean, I think you're right. I think it could make an impact on the age demographics for sure. But
the second wave of this is mostly a young person disease, isn't it?
Yeah, but they don't die.
They don't die.
That's what I'm saying.
So I'm looking
exactly
here
right.
I'm looking here at my favorite. This is a small sample, but it's once again the metropolitan statistical area around Austin, and looking at the deaths so far. Once again, this is a small sample. We're talking about just a couple of hundred, but 37% and 31%, 60, almost 70% of the total deaths are in ages 70 and above.
Yeah.
Okay.
Yeah.
And
that's always been true, though.
If then you have to, if you say something, if you give that as a number, it's disproportionately older people. We already knew that. Mm-hmm. But you can use that number and drive it out and say we have to infect 80% of the population in order for this to reach equilibrium, that 1% of those people are going to die and 70% of those people are the older people, and work out the demographics. It's going to have a bigger dent, I would think, on the older population, but I don't think it's going to, it's interesting because I think the infection fatality rate ultimately, I'm guessing, is going to be less than 1%.
That's okay, of course.
And so that's not to belittle if you get rid of 1% of the population, even if 70% of those are the old people, it's still going to look pretty much the same. That's not to belittle the problem. That's a lot of people.
Sure.
Okay.
True.
Yeah, sure.
So we're in the process right now of doing a census.
Yeah.
And we can compare that to the 4 years ago when we did it then. And do you expect there to be any difference?
Well, don't we do a census every 10 years?
Yeah, we do.
Is it 10?
It was 10.
Yeah, it is 10.
But
all right, say 10 years ago.
I think it's important to remember that this is going to vary tremendously across geography.
Yes.
Globally, there are going to be enormous differences. There are already major demographic differences between different countries, but if you imagine countries that have a large aging population but did a good job controlling the pandemic, I'm thinking of Japan. I'm not sure what demographics are in South Korea, but I think they have a fairly large older population as well.
They all live in Fort Lee.
Okay, but places that did a good job controlling the pandemic are going to see no particular impact because they did a good job controlling the pandemic.
Yeah.
If you go to Florida, which is basically a nursing home with ocean on three sides, then and they did a horrible job controlling the pandemic, and it's not clear they're going to get it under control at all, I think you may see a significant demographic impact there. And it's going to vary state to state across the U.S., and it's going to vary tremendously country to country around the world. And I think the impact could be significant in some places. I don't think Canada is going to need to worry about this nearly as much as we are.
No, that's true.
But I actually have to go at this point. Got to go pick up my kid.
Alan Dove, turbidplaque.com. Alan Dove on Twitter. Thanks, Alan.
Thank you. It's always a pleasure.
See you next time.
Take care.
Have a good holiday. Enjoy the fireworks and parades.
Exactly.
Right. Well, I'll just have some steaks on the grill out back.
So, Alan, for fireworks, just turn on Fox News.
Right. No. Thank you. Take care, everybody.
Bye.
See you,
Bye.
Alan.
Brianne, you're next.
Sure. Michelle writes, "Hi all. All I want to say is that I absolutely love your podcasts. All of them. I love the science, the humanity. I feel you are all my best friends despite never meeting you.
Ow! I love it.
You are the silver lining in all of this. Knowing that there are honest, intelligent, unassuming folks like you in the world is tremendously reassuring."
Oh, that's such a lovely letter.
That is very nice. Thank you so much, Michelle.
Michelle is a physician.
She's a physician in,
Go ahead.
It's okay. Physician and musician in New York. New York City.
Interesting combination.
That's great.
Dixon, in your estimation, are many physicians musicians?
A lot of them are.
Yeah.
A lot of them are artistically bent, as it were.
Okay.
And either paint or play musical instruments or sculpt, or they do something that distracts them from the seriousness of their occupation, so they can have a reprieve from their day-to-day life, basically. And I think that's the way it is.
My experience is that the kind of people who become physicians, they're motivated individuals.
Yeah, that's right. Plus
so they do lots of stuff.
And they pick up a lot from their patients also. I don't mean diseases. I mean ideas. They converse with them. The good ones get to know them. And really, are you doing that? I wonder how you do that. Is you have a lot of fun? Where do you go to do it? And the next thing you know, the guy is doing it or the woman is doing it also. So, I think broad breadth and depth. In fact, I must tell you, I served on our admissions committee, and Rich, you served on the one in Florida for many years as well. You look for people like that to begin with.
Sure.
They're not physicians yet. These are people coming in with all of these talents, and then they become a physician.
I hate committees, but I loved that one.
Yeah, me too.
I
served on that until I figured I'd done 30 years. That's enough.
All right,
I was out of date, not them.
We have a poem sent in by Felicia, who's a professor of chemistry at Virginia Tech.
Right.
What if, it's called, what if the whole world agreed to stop everything for just 2 weeks? We could beat this virus down to 0. What if we all agreed on August 1 to 14 as a 2-week period of complete household isolation ahead of time so we could plan for it? We could beat this virus down to 0. What if we all stocked up on food for 2 weeks and shut down even grocery stores? We could beat this virus down to 0. What if we could provide food and isolation housing in hotels and dorms to truly essential healthcare workers, emergency medical technicians, water purification and sanitation workers, electricity workers, firefighters, and homeless people for this 2 weeks? We could beat this virus down to 0. People would stop dying of COVID-19. The economy could swing back fully instead of a weak pendulum of reopening and reclosing. We'd save billions of taxpayer dollars. Grandparents could hug their grandchildren again safely. People could date again safely. We could go back to work. We could go back to school. We could go back to sports and concerts. We could make this madness go away. Sorry, no.
Set to the tune of Lennon's Imagine.
Yes.
Yeah, it could do that, but I'm afraid it can't work. Sorry. There's always somebody that's not going to be, well, first of all, 2 weeks is gray, is not absolute. There's always going to be someone who's infected for slightly longer because that's how viruses work, and that person will start it all over again. And I don't think you could have everyone shut down. Just there's some people who are going to have to work. I know you listed all these people. But every person in every country would have to do it, and just because of that, it would be not possible. But it's a good idea.
Yeah, what if?
Alan is gone. Rich.
Jesse writes, good morning. Listening to TWiV this morning, I heard several comments relating to the surge of cases in the 20 to 40 age group. While a lot of this may be due to people in this age group patronizing bars as they reopen, it is important to remember that these cases may be the result of choices these individuals make on their own. It is important to remember that this age cohort is vastly overrepresented within the front line of many service industries. As restaurant and bar closure restrictions fall away in the rush to restart the economy, these workers are then ineligible for continuing unemployment benefits. These people have no choice but to return to work and expose themselves to unmasked populations. Can't wear a mask while you're eating in a restaurant. And of course, The clientele opting for dine-in service may be within the same age cohort, but it seems likely that the customers are predominantly older and of a more comfortable socioeconomic position. I really enjoy listening to TWiV, but please don't shame an entire population based on anecdotal reports, and encourage your listeners to support local restaurants with takeout and still leave a tip whenever they can.
Yes.
Take care, Jesse L. P.S. Not a server, but have been one in the past.
That's a very good point, Jesse. While we do say a lot about, those people going to bars, there are many people in this age group who are doing things because they sort of have to, and we shouldn't shame them for that.
Yep.
All right, Dixon.
Barry writes, "Hi, TWiV. I will try to make this short, though please know that my admiration for your information and efforts is deserving of many pages of praise that I leave to others with a more poetic bent than I. I know that what I'm about to posit is nothing less than heresy, but here goes. Could the virus be mutating, but only in limited, special, highly constrained situations? In Victoria, Australia, we're the last state to have SARS-CoV-2 in community transmission, and we are having outbreaks now. We had the hardest and longest lockdowns compared to the other states, but yet we still have transmission and outbreaks seemingly from asymptomatic carriers. Virtually no one in Australia wears a mask anywhere, except healthcare workers at hospitals. We seem to rely heavily on Tetris to do the heavy lifting and keeping us safe from outbreaks. Most people get tested when symptomatic. In Victoria, we are also genome sequence. In Victoria, we also have sequenced the genome of the virus from 75% of positive test results, which helps track where spread and outbreaks have come from, even when geographically distant and seemingly disconnected places are involved. I'll just add that in there. There will be a documentary about this one day, I'm sure, and he gives a context to this. Under these conditions, where the virus is not barred from transmission by its host wearing a mask, and only virus that presents as symptomatic disease is quickly nipped in the bud through Tetris, pardon me, do you agree that there may be some small selective pressure on the virus to present with less severe symptoms? If you agree, then the question is one of time. How long is enough to see the virus become milder? Pardon that interruption.
You don't have to take your thing off. You can just hit the mute button.
Yeah, I thought about that too late. Perhaps with the genome sequences in hand, which they are, one could correlate different strains of the virus with different severities of disease. I expect I will not like how little difference it makes, but maybe not. Vincent, you were shaking your head no the whole time I read this, so you go first.
All right, so he wants to know if there's any little bit of selection by the procedures that we're putting on people for reduced virulence or maybe increased transmission, to which I said no. Even though these procedures we're doing, these shelterings are nowhere near effective enough to make an impact on to serve as any selection for the virus. Okay,
sure.
So I don't think this is happening, and there's no evidence that there are different strains throughout the world with different severity of diseases that they cause. Absolutely none.
By the way, I'm sorry, go ahead.
And how long do you see the virus becoming milder? Well, this is theoretically possible, but I don't know. Who knows? I mean, in fact, it's been theorized for other viruses in the past, but the evidence is not very good because it's hard to do that experiment in people. So
Australia is a country that only has about 25 million people.
Yeah, it's very low.
They've only had 18,000 some odd cases altogether.
Yeah, they're too far apart from each other.
18,000, Rich, you've got 18,000 in your neighborhood. And that's the whole country of Australia for the whole outbreak.
Most of the people are in the cities, right, Dixon?
Yeah, sure. But, I mean, if you look at the way they handle this infection, it's incredible. I have a good friend who went down to the countryside in his mother's country home to hunker down for the duration. And everybody hunkered down, basically. They just stayed in their place. And
it's not because it's a different virus. I'm just saying that
it's not a different virus.
The environment is somehow
different people.
Different people, different geographic situation. What it is exactly, we don't know, but the viruses are all the same.
Yeah. Go ahead, Rich.
No, you go ahead, Brianne.
I was just going to say that people have a lot of ideas about viruses mutating quickly when they think about influenza or about HIV.
HIV, right.
But, measles is largely one strain. And so there are lots of viruses that are important human viruses that have been around for a very long time that seem to really only have one strain. And coronaviruses don't mutate particularly fast, is my understanding.
My sense is that, just the kinetics of how something like this happens play into what you actually observe. With a certain number of certain population density and a certain number of beginning cases, it's logarithmic. Okay, so it sort of stumbles along for a period of time until you reach some sort of critical mass, and then it apparently takes off. But it's a doubling time phenomenon.
So this virus hasn't changed its way of entry into a cell.
No.
From the very start.
Nor reproduction, nor exit.
Right.
It's all the same.
I mean, we have viruses like West Nile virus, where you've got insect vectors to contend with, which gives it a chance to have to adopt to a different environment.
Yes, those are very interesting.
So
we've talked about this before, but the best documented example I know of a virus becoming more attenuated in a natural situation was the introduction of myxoma into Australia. And that occurred after a first pass where over 99% of the rabbits were wiped out.
Yep.
And some resistant rabbits began to arise. And I'm hoping we don't get to do that experiment
I don't think so.
Anytime soon.
No, the mortality rate is much lower, as you know.
Rich, did I tell you about my colleague who took students on a study abroad trip to Australia? And at one point he looked at me and he said, we're meeting one of our speakers in the Frank Fenner room of the Frank Fenner building of the Frank Fenner area. Who's this Fenner?
Nice. Does anybody here besides me claim knowledge of actually having shaken that man's hand?
No.
Yes, me. He used to come to POX meetings. As a matter of fact,
there you are.
He submitted a paper for us to PNA.
I had a sit down with him once. It was fascinating.
No, I didn't have the opportunity. All right, Brianne, you're next.
All right. Tim writes, "Hi, TWivers. I just read the Washington Post article. Coronavirus autopsies, a story of 38 brains, 87 lungs, and 42 hearts." And he gives a link to this article. "It was incredibly intriguing to relate the dengue fever discussions and discoveries from 633 to the comments in the Post article, to the point where I wondered if TWiV has been ordering the sequence of some of these shows to help us understand where some solutions may ultimately be coming from. Or is it just the fortuitous effects of knowledgeable experts? Anyway, I am beginning to believe a whole lot of the broader journalist pools need to make you regular listening. I would also be interested in your observations on the effects of the changes in communications channels and processes as a result of the pandemic. You all seem very comfortable with the plethora of unanswered questions you face daily. I think we all need to develop better acceptance of those uncertainties and risks." Yeah, I think that being sort of comfortable with unanswered questions is part of being a scientist.
Yeah,
exactly right.
Yeah.
You all day.
And there are questions.
So this
makes it even worse.
I'm very glad that he mentioned this. I mean, the thing is, you can learn from any virus about any other virus. That's the cool thing. And that's why, I put up a Singapore episode on mostly dengue, and it's relevant because, the enhancement of disease in dengue, which may or may not be happening with COVID-19. But you could put up almost any other virus podcast episode and it would be relevant. And that's why I said a few weeks ago, you should listen to all of them because you're going to learn something. You don't have to, of course, but and it doesn't matter to me really, except that we're trying to teach you, and it would I think it's good to pick up it's like cutting lectures, I don't want to go to that one. It's part of a course which has been planned by the professor, right?
And if you haven't learned it yet, how do you know you don't like it?
Aha.
Indeed.
I saw this article when it came out, but I didn't read it. Have any of you read this particular article?
Yeah, it's basically about, doing autopsies and finding out what's going on inside besides in the lungs, right? And they compare it to dengue enhanced disease in many cases, right? Because some of the things they are seeing are very unusual for this infection. And that's why this listener, because he listened to the dengue episode. The other thing is how did the journalists should listen, but they're too busy. They have no time to listen, and they prefer to talk to the primary sources. I understand that part, but not having a lot of time is really a poor excuse. And if Alan were here, he would talk about this. But journalism has changed so that a lot of the online stuff you have to crank out very quickly. You don't have a lot of time to do long form. You don't have a lot of time to check your sources and so forth. It's really a big problem. And so I think that's how communication has changed as it's moved to online, where you have to make multiple posts in one day to get people to click, because it's all ad driven. Totally screwed the whole model up, I think. And it's still evolving as far as I can tell. Let's do one more round. Saul writes, "It's no big deal for me to wear my mask properly, and I often nudge other people to wear their masks over their nose. But I'm wondering if I might leave them alone, especially in situations where they might be sitting more than 2 meters away or outside. What's your learned approach?" Saul from Israel. P.S. I'm a recent listener. While much goes over my head, I benefit immensely from the rest. Thank you. May the virus go over our head as well.
Well, I knew there was a reason I was short.
I think so. Being outside is difficult because you just never know when someone's going to turn up, right, and walk right by you. So for that reason, I wear my mask outside. But maybe you could leave them alone and just move away because somebody's just going to get mad at you, and that would be my approach. I wouldn't say to someone, "Put your mask on." I'd just go somewhere else.
I think you're right. I like Alan's comment that fighting is a risky behavior in terms of transmission.
Yeah, I think so.
Rich.
Fred writes, "Hello. I have a couple of thoughts around masks. I see quite a lot of people that don't seem to know how to properly wear a mask. They push it under their chin or let it hang down on one of their ears or just taking it on and off whenever they need to eat or drink or talk. How does this affect protection against the virus? I guess the risk is mainly that you will risk to infect yourself rather than the other. So is it a case of you only have yourself to blame? How much does it differ between homemade and real masks? What about us that have a hard time wearing a mask? Is it enough that a majority wear it, or should we stay away from people until the vaccine is here? One friend suggested that I could wear a hat like beekeepers have. Would that be enough to protect others? If you have antibodies, would you still need a mask? Whoa. Okay, so these are all the mask questions. First of all, my understanding, a homemade cloth mask is not going to be as effective at actually filtering out viruses than one of the like N95 hospital masks. But you don't have to worry about that anyway because you're not going to have an N95 mask, and even if you did, it wouldn't be individually fitted. So, you're going to be in the cloth. Most people are going to be in the cloth mask situation.
But as Alan said, we don't know. Nobody's compared these things. The surgical mask versus if you have a thick cloth, it's going to catch the droplets. I think it's fine, right?
And my understanding is that the biggest effect is on preventing spread from people who are sick to people who are not sick. Though there is some effect of not getting sick. So to a large extent, one is wearing a mask as a social responsibility. to protect others around them. So to some extent, you are protecting yourself as well.
Mm-hmm.
In terms of how to wear the mask, basically, we're talking time and dose, dude. The more you wear the mask and wear it properly, covering your nose and your mouth, the better protected you are. And the more you fiddle around with it, if it's got any virus on it, the more you're going to spread it around. So put the damn mask on, put it on properly, and leave it there. And it's not a big deal. I wear a mask. It's not a big deal.
And speaking of properly wearing a mask, if you have long hair, your long hair should be tied back so that your hair isn't hitting the mask.
I'll tell you the big problem here for an old guy.
Is that what you are?
Yeah. And I wear hearing aids and glasses.
Uh-huh.
Okay. So there's not a lot of real estate left behind my ears for the things on a mask. So I'm slow, and I have these homemade masks that I make that have pretty thick elastic on them. So I'm slowly learning how to, I mean, this is maybe too much information, but how to tuck the bands from my mask down under my hearing aids.
Yeah, good.
But it works. Okay, take the time. Take a little effort. It's not a big deal.
I think there are some people who cannot wear masks for good medical reasons, and they are a small percentage, and I think that's fine. I don't think that impacts the overall effect of the mask, right? You don't need to be 100%. I think it's kind of like herd immunity, right? If enough people wear masks, it cuts down the transmission. What, 70-80% is what you need for herd immunity for this virus? So I would assume that similar number, maybe it's slightly higher for masks.
Wear a hat like beekeepers.
I think those are too porous, those things.
Yeah, those are too porous.
Yeah.
I do notice in a lot of healthcare situations, people wearing the face shields.
Yeah,
I see that a lot. Yeah, I do see that a lot.
And that would probably keep you from, it wouldn't protect you from picking up virus, I don't think necessarily, but it might help limit to some extent the spraying virus around from you to other people.
In some stores, there are big plexiglass shields in front of the cashiers and the customers, which is good because it prevents your...
True.
They're very high, so your aerosols are not going to go up and over them. I think those are.
So if you have antibodies, do you still need a mask? The truthful answer to that is we don't know. Okay, because we don't know whether you might still be shedding, whether you might still be able to catch disease again. My guess is that your risk is decreased if you've been infected and have had an immune response, but there's still a lot of unknowns with this.
All right, Dixon.
Okay. Bing writes, I won't read the first part. This is okay. Here's today's lament. The inconsistent basis on which COVID-19 testing is occurring makes it almost impossible to interpret the large-scale data. There is no plan to use even 5% of the capacity in a statistically meaningful way.
Yep.
That would be more than enough to get an accurate handle of the real prevalence, spread, and consequences of COVID-19. But the current behavior of seeking and getting testing is almost impossible to model. The brilliant work of Seattle Kings County Health Department, Mass General Hospital, and a few others I don't know about will be our only hope to learn what we need to learn from population studies. And this guy speaks from authority because I think he's a biostatistician.
Retired FDA biostatistician.
That's right. Remember the definition of a biostatistician.
What's that?
It's a mathematician broken down by age and sex.
That's good. That's nice. I agree. I think that you can get a handle if you have a good population designed for a study to know what's going on from 5% of it, right? But you have to design it. You can't just have people randomly coming in.
No,
I totally agree. And that's not, but Seattle and Mass General, it's being done as well.
They did random testing, I guess.
No, they had very carefully designed studies to find out the prevalence in the overall population. All right, one more from Brianne.
All right. Dimitar writes, yesterday, I stumbled upon an announcement by a UK government official, which I find quite peculiar, even for politicians who have made a profession out of the habit to overpromise. Here's a transcript of what Alok Sharma, the UK business secretary, said during the Sunday COVID-19 UK government briefing, as quoted by Sky News and accompanied by the video footage of him saying it to verify the validity of the source. And then he gives a link as well as these two quotes. This new money, £84 million, will help mass produce the Oxford vaccine so that if current trials are successful, we have dosages to start vaccinating the UK population straight away. This means that if the vaccine is successful, AstraZeneca will work to make 30 million doses available by September for the UK as part of an agreement for over 100 million doses in total. Could you please evaluate this statement as scientists who have insight into vaccine development? How realistic is it to develop from scratch a working vaccine in such a short time and plan to vaccinate 30 million people with it? What could go wrong?
Well, okay, go ahead.
No, you go ahead.
So
you go ahead.
the Oxford vaccine is an adenovirus-based vaccine. The technology for growing adenovirus-based vaccines is quite well worked out. Now, I don't know the specifics of the chimp adeno situation, but I do know that in the case of some other adenovirus vectors, they're growing these on cells that grow to an incredibly high density and generate a lot of virus per cell so that you can get a lot of doses out of a fairly small volume. So I don't know about the specifics of these numbers, but I wouldn't discount it right away. I think, and also it's clear that the pharmaceutical companies and the governments in collaboration with each other are compressing this effort. So that rather than wait until the trials are done and then produce something, they're going to go ahead and produce it banking on the trials being successful. So personally, although I don't know enough about the situation in this case to crank the numbers myself, I wouldn't necessarily discount this as out of the question.
I think that the numbers I would agree with Rich about, but the September date still does seem awfully early to me in terms of having trials done and knowing about vaccine safety and efficacy.
Yes, agreed.
Certainly with respect to getting a trials done, I absolutely agree. September is pretty early.
It is.
That's right around the corner, dude.
Yeah.
Yep.
Limiting factor, as I understand it, is that they don't have enough vials.
Dixon, you turned your video off.
How did I do that?
I don't know. But fortunately, we're done. There you go.
Oh, there you are.
Again. I know how to do these simple tasks.
Good. All right. That's episode 635, microbe.tv/TWiV. You can find the show notes. Send us your questions and comments, twiv@microbe.tv. If you like what we do, you can help us out financially, microbe.tv/contribute. Dixon Despommiers at trichinella.org, thelivingriver.com. Thanks, Dixon.
You're welcome. It was a good time.
Have a good 4th of July.
Yeah, it's good.
Brian Barker is at Drew University on Twitter. Bioprof Barker. Big fan of pizza. Thank you, Brianne.
Thank you. It was great to be here. I am going to celebrate my 4th of July by watching Hamilton.
Cool. You're not going to the theater, though. You're going to watch it on TV.
They have released it on TV today.
Nice. Very
good.
And they eliminated the F-bomb.
They eliminated 2 of them.
There's an F-bomb or 2? Yeah.
There were 2.
There's 3. And
they kept 1 in?
Yep.
Rich Condit,
Aaron Burr did that one.
Rich Condit's an emeritus professor, University of Florida, Gainesville, currently residing in Austin, Texas. Thank you, Rich.
Sure enough. Always a good time. And Brianne, I'm right there with you. We're going to be watching it tonight with the extended family. I confess that over time, there are 2 households here, myself and my wife, and my daughter and her husband and the grandchildren. And over time, I think that we have decided that we are, in fact, one household.
Mm-hmm.
Okay?
Yep.
And although there's not a lot of hugging and kissing that goes on, where we spend time inside with each other now. And I think that that's legitimate. So we're going to watch Hamilton together tonight and have Chinese takeout.
Enjoy.
Nice. You too, Vince.
Thank you. I'm Vincent Racaniello. You can see me. You can find me at virology.blog. I'd like to thank the American Society for Virology and the American Society for Microbiology for their support of TWiV, and Ronald Jenkins for the music. This episode of TWiV was recorded, edited, and posted by me, Vincent Racaniello. You've been listening to This Week in Virology. Thanks for joining us. We'll be back next week. Another TWiV is viral.